Just
No,
wait,
sir.
just wait.
No,
Just
no.
the YouTube now. It's live streaming side by side.
Oh,
So
great.
welcome everyone to this another session of PPF, where we'll be dealing with especially the problems of the practitioners of South Zone. And the first was about the West Zone practitioners. I think it's a wonderful initiative by the Governing Council, and Dr. Pankaj is leading the PPF as a program head. So in this session, I think what I anticipate, our Governing Council anticipate that we will be able to interact with as many practitioners to hear from them also, so that so much august panelists and speakers are there. We'll be able to answer all the things, and I think from these onwards, we will be able to carve out a good path. After the 6 months, we may be coming out with a good strategies from ISA National, so that we can formulate the such strategies to deal with the problems of individual private practitioners at the city level. So this is a good initiative. I congratulate everyone from the Governing Council who have been very much kind in initiating these type of webinars. Now I request my GC colleagues, Dr. Pankaj and Dr. Srinivas, to say a few words before we kickstart today's program. Dr. Pankaj and Dr. Srinivas first.
Yeah, good evening, everyone. Always good to interact with all the private practitioners in the country. And just as we are discussing the problem in South Zone today, on 25th June, we plan to have the discussions of the East Zone. So I'm sure that we'll have a good interactive session, a good panel discussion. And I feel it's a wonderful initiative by National ISA. And Dr. Bajwa has been at the helm of affairs for everything that we have been doing. So I welcome all of you to this session. Thank you.
Dr. Srinivas.
Yes, sir. Yeah. Good evening, sir. Good evening, all the private practitioners, ISA members, and all my colleagues and seniors. And this is a very good initiative to talk about the issues of the private practitioners, their problems they are facing. Okay. And today's program, especially, it has got very good topics, starting from the record keeping and on the table death. What should we do? How we should approach when there is death on the table? Yeah, it is a very good initiative. I am very much confident this will be very useful to all our colleagues. Thank you. Thank you for the opportunity. Okay.
Thank you. Thank you, Dr. Srinivas. And now our president, sir, is here. He is driving. Sir, I request you to stop driving for a while take the car on the side and give your advice for at least 2-3 minutes. Side on the side.
Dr. Bajwa. Yeah, good evening, Dr. Bajwa. It's easier in Mumbai to stop the video rather than take the car to one side and wait. So I think I'll just do that. So
your choice.
Yeah. So congratulations once again for the Private Practitioners Forum, Dr. Pankaj Gupta in particular, for organizing this meeting. I think last time we had a meeting of the West Zone practitioners, and this time we have the South Zone. ISA is committed to helping and addressing the issues related to all anesthesiologists all over the country. And Dr. Gupta, Virendra Sharma, Dr. Sethi, and all have been very vocal and very passionate about the issues faced by private practitioners. And this is a very good forum and a good way where we can discuss the issues that practitioners face all over the country. And I think the zonal part is also very good because different issues have a role in different parts. And I'm sure all of us have a lot to learn and a lot to understand about how anesthesia is practiced and what are the problems faced in all different parts of the country. So I welcome this initiative and I hope to learn a lot, and I wish you all the very best. And thank you very much for starting this program.
Thank you, sir. And thank you for your kind words. And I think under your guidance, we are leading the path to a good glory for ISA as well as for our fellow anesthesiologists. And today, starting the program, we are having Dr. Vibha Nayak and Dr. Alla Prasanthi. If somebody really asks me to introduce them, I think they are not asking for a justice, because these two people, they don't require any introduction in India. So Dr. Vibha Nayak and Dr. Alla Prasanthi, ma'am, without even showing your CV, I request you both to kindly take over the session from here. And pardon me for not introducing your full-fledged slides here. Just, but request you to take over. People will come to know today also when you will be taking over the program. Please,
So Dr. Indrani has just joined. Indrani Hemant Kumar.
Madam is there.
She just joined.
So
I just
Indrani
saw her.
madam, if she's there, so she can turn on her video.
Indrani,
Okay.
madam? Okay, we'll get her in the panel discussion
We
later.
can have after the first lecture,
Yeah.
let the program
Yeah.
start.
Yes.
Dr. Biba and Dr. Prasanthi, ma'am, please.
Just a moment, I'll just turn on the video. 1 minute, 1 minute.
Okay,
Yeah.
okay. We will wait for. Ma'am, and without video also you can
Yeah.
share the thoughts.
Madam, you can just speak, madam. No problem. Indrani, ma'am. Just cut.
I think she may have got technical glitch. So I request Dr. Biba and Dr. Prasanthi, ma'am, to continue the things. In between, we can get a message from her.
Thank you, Dr. Bajwa, sir, for your kind introduction. And I thank Dr. Pankaj Gupta, sir, for taking this lead to start this wave. It's like a Udyam of private practitioners forum and making a platform to do webinar series on private practitioners' problems, what they are facing in day-to-day life. So today we have 4 topics, and I request Dr. Biba to take over and introduce the first speaker. Thank you.
Dr. Biba, Dr. Biba, Dr. Indrani is there. You can request her first before we moving forward.
Yeah, sure. Good evening, Indrani ma'am. Please, can we have a few words from you?
Good evening, everybody. It's a full private practitioners forum and very, very relevant topics. I really loved all the topics which are going to be discussed today. I'm really looking forward to listen to what is different in the private practitioners, side of all these topics. But one thing which is common and why I feel today's webinar is important is this medico-legal issues directly, affects patient care and safety, where we can never take any risk, So that is one thing. So probably, and as professionals, it also gives us that responsibility, so that we align with the medical standards and the legal requirements and we follow. So that one, and we know how much of risk, I know in the private practitioners, the kind of risk people take are much, much higher as compared to us who have been working in government setups, definitely, there are few compromises which one does dwell in the private practitioners, even though in government there is no doubt that those cases which are rejected in the private do come over in the government setup. But then the kind of infrastructure and the kind of number of people to help us is also that much more as compared to a private practitioner where they do single-handedly, they manage and they try to manage difficult cases single-handedly. So all these are very, very important, and importance of consent. And I myself have a couple of questions after the, ringing in my ears when it comes to consent. So that probably, as the CME goes through, then probably, if I get the answer, fine. Otherwise, I will ask the question. So I'm just really looking forward for this CME, and all the best for a good one. Thank you so much for having me here.
Thank you, ma'am. Thank you for your kind words of inspiration. And good evening, respected seniors and dear friends. Today's session, we have some hand-picked topics as well as speakers, and I'm sure you've all joined in great numbers. For the first topic is very, very important, like Indrani ma'am said. If there were to be any medico-legal case, then the documentation and the consent are the two most important things that would matter. And for this topic, we have our first speaker, Dr. Shyam Perry, who's graduated from Rangaraya Medical College and has had anesthesia training from Andhra Medical College and Care Hospitals, Vizag. After being in private practice for 15 years as head of a group, Morton Anesthesia Associates, now he is managing director of Oxycure Hyperbaric Oxygen Therapy Center. So he has interest in hyperbaric oxygen as well as medical designing. He has co-developed an app called as PA Consult app. So over to you, Dr. Shyam.
Yeah. Good evening, friends. First, let me share my screen.
Till then, I'll just request the audience to keep chipping in the questions that you would want to hear answers to in the chat box, and we'll be taking them at the end of all the talks. Thank you.
Sir, Dr. Arunendra has joined. Can we make him co-host so that he can be speaker?
Yeah. What is the screen name? Screen name?
Dr. Arunendra. Arunendra RV.
Just a minute. Let me see, ma'am. If it turns on the video, it becomes easier, na? That's why.
Yeah. So, are my slides visible?
Perfect, sir.
Yes.
Yeah. Good evening, friends. Today I will be talking about overcoming the documentation and consent challenges in private practice. This is a topic that is very dear to me because since last 2 years I have been writing down what are all the issues that I have faced, and I'm trying to solve them one by one. So most of my journey in the first 15 years was like routine practice, doing every day, means working from morning 8 to evening, say 10, 11, without any mind and running after the practice. But 2016 has been a time, like a watershed moment, where I changed the way I started working. And from then on, it was like, what are all the challenges that we are facing and how we can improve that? And I stopped being very aggressive in the practice. From then on, I was a bit laid out back and started focusing more on design and development. So most of the things that I work on are all the challenges that we are facing and how we could solve, because nobody else is going to solve our problem. So yeah. So I would be talking about the need for documentation. What are the challenges that we face in freelancing regarding the documentation issues, and what a consent means, what is the proper way of consent, and what are the major pitfalls that we face in consent, and why preoperative checklist is important and how it is going to help us with the safety of the patient as well as our own safety during a medical legal issue. And finally, I will be talking about the resources that are available where we could address these challenges effectively without a break or a change in the way we work. So all the focus would be on integrating the safe practices and safe documentation practices into our practice without breaking the way we work. So I'm not going to talk about PAC, intraoperative and postoperative review and logbook, which are all very important documents, but they are big topics in themselves and need much a more elaborate discussion. So why do we need documentation? The first and foremost is what should we be doing with the patient? To plan that, we need proper pre-anesthetic checkup and all the details that come with it. And it is also the way in which we record events, because these recording of the events are the documents that are going to help you in future for reference as well as for the medical legal purposes also. And recording of complications, especially like an airway complication that has occurred like 10 years back, that patient has come up for GA again, and we don't find such a record. And that's where we are definitely going to land in complications. And it would be a guide to our future course of action. So yes, this fellow had a difficult intubation. Next time, maybe we could be doing a regional or a planned fiber optic. These things, course of action could be jotted down, right? Because if we know what has happened in the past. So without the knowledge of history, we'd be very much in the dark when we are dealing with the patient. And most importantly, all the documentation is the only thing that is going to save us when there is a medical legal issue. No matter how good we are and how skillful we are and how much we have served the hospital, it is finally the judge who is going to decide whether you are right or not. And he doesn't know all your background. It is just like an external examiner. He will see what you are doing and what has been written there, and based on that, he is going to give the judgment. So unless we document whatever we have done, or sometimes what is the proper thing that we have done, otherwise we are not going to have any leg to stand on when there is a medical legal issue. So these are the following challenges that we face in private practice regarding documentation. The setups are very much varied. Some are very basic, where only paper is available. Some are having really high-end electronic medical record systems. So the standardization is not there. At one place, you will be just giving this final and going off for the next case. In one place, you have to fill in the whole forms before you even start the case. And electronic health records, technological barriers are the major issue. Electronic health records are not the same everywhere. Each place has its own kind of format which needs to be followed. And again, accessing them again is a major issue. It means this fellow means the patient had been operated in one hospital. Again, when he comes to another hospital, the electronic health record that is available previously is not available here. So there is a lot of silo kind of thing, and there is no proper integration. Though the government is trying to change all that, but it would take some time before all this is going to change. And regulatory compliance, there would be guidelines that you should be following, and various kinds of documentation that you have to follow, which varies from place to place. And again, time constraint is the major thing, because proper documentation needs a lot of time. So it would be like almost at least 1/3 of your workload. So if you could manage your documentation on the go or when you are working on the phone, that is one thing that is going to really change the confidence with which you can document the cases. And just not you being aware, the whole ecosystem in which you are working has to be aware about the importance of documentation and what are all the things that you are going to look for, so that the hospital also gets those things ready by the time you are there. So training and creation of awareness is also an important part of our job. It's not just that it is something as an add-on. And resource limitations, they are there everywhere, even in major hospitals. Sometimes resources become a crunch. And communication gaps, especially during handover and takeover, and the proper documentation is where majority of the issues will be coming. So I would be talking about the consent first, then I would be outlining how we are going to solve most of the challenges, because consent is one thing that is very important that has to be done in detail. So the first and foremost thing is the consent has to be taken by the doctor who is finally going to administer the anesthesia. It has to be done by the doctor who is going to administer the anesthesia. And it has to be very specific for the procedure and for that patient. That is, it cannot be like this patient is going to have general anesthesia with so and so complications in the printed form, and you tick the general anesthesia and you take the signature. That is not going to go as a valid consent in the court of law. The consent has to describe what the procedure is and what are the issues that the patient is having and what could be the expected complications and what are all the other things that could be a change of plan that could happen, all those things. And need for blood transfusion itself is also an important part of the consent. And the consent should be taken from the patient himself if he is a legally consenting adult, except in cases of people who can't take the consent by themselves, where a proxy is taken, or like children. Otherwise, any consent that is taken except from the patient is null and void. And consent also should be free and voluntary. That is, the patient has to give the consent. It can't be coerced because just as he is going into the OT, you please sign here. That is not the way consent is taken. And it should be informed. The patient should know all the pros and cons in the language that he understands, and then only the consent is valid. So, and if the patient is having multiple procedures like blood transfusion, etc., the consent has to be a separate one, not a single. And if the patient is having the same procedure again, like a re-exploration after a laparotomy, again the repeat procedure again needs an anesthesia consent. And surgical consent is not sufficient to cover the anesthesia consent. So anesthesia consent has to be separate. And if the best way is to handwrite it, a page or a two, and take it. But obviously, because of time constraints, we are using printed forms, which might not be useful when it really matters, when it is in the court of law. And unless the consent is signed by both the parties, that is the patient as well as the doctor, the consent is not valid. And if a witness is also there, that would add a lot of weight to the consent. So it should be properly documented and filed, and the consent can be withdrawn by the patient at any time, and that has to be again documented into the patient record. And any illegal procedure like illegal abortions, etc., there the consent, even if it is taken in proper way, it is invalid. So anything like a undocumented kidney transplant, if you have anesthetized and taken consent for it, it really carries no meaning. It's a paperless kind of thing that is being done. And consent is no defense in case of a professional negligence. So even if we have a valid consent, if there is gross professional negligence and which could be proved in the court of law, consent is not going to protect us. So again, the things that I have mentioned which should be done are the pitfalls that usually happen. So when we consider that the procedure is a very small procedure and but it is still invasive, then we don't take the consent, then that is going to cause a problem, like a femoral line or a temporary pacemaker implantation, etc. Those things. If we take the consent from the relatives instead of the patient, because the relatives might have asked for it, still the consent is not valid. And if they would take the consent from a person who is not legally valid to give a consent, that is also a problem. Like if the patient is minor, or is intoxicated, or is not sound in mind. And a blanket consent, like I have said previously, that we are going to give GA and this is all the problems, etc., in a printed form, usually that is going to have a problem. And it is not procedure specific, that is what is being done, and those things have to be documented in detail. And if for a blood transfusion has been done and the consent has not been taken, then it is going to be a problem. And repeat procedure, because the same procedure has been done again, if we don't take the consent, that again amounts to a documentation lapse, and which might be adversely affecting us in the court of law. And necessary information, that is usually when we get the cardiac evaluation done, they would write mild, moderate, or severe kind of risk. So what really amounts to this mild, moderate, or severe risk has to be explained to the patient. Mild is like around 5%, less than 1 to 2% of complication rate. 5 to 10% would be the moderate, and 10 to 15% is the severe. So of major adverse cardiac events, this has to be told and written in the consent before we say anything. So it has to be quantified. That is how the information needs to be given. It cannot be in very vague terms, like it is a very high risk case. So what are all the risks involved? What could be the percentage of those complications? All these things have to be documented, which will add weight to what we say when there is a dispute. And if we don't sign the consent, then the consent is not valid right at the start itself. And if there is no witness, then the legal standing for the consent comes down a bit. So it is not like it is going to be improper consent, but if there is no witness, the strength of the document comes down. And there are alterations or additions where the patient has not countersigned, that again is going to be a problem in the court of law. So, and why preoperative checklist is important. This is also one thing that means this comes as a document, and in most of the private setups where I have worked, there was no preoperative checklist unless it was an NABH accredited hospital and going for NABH accreditation. Otherwise, we never worry about this. But it is a kind of document which is going to save you a lot of medical legal issues in the future. So because it helps you and it tells you that, or it is the document which proves that you have identified the patient correctly. So the problem of wrong surgery or the wrong patient doesn't arise ab initio. And surgical site, wrong site, etc. Those things also get confirmed here, because wrong side surgery is an issue for the anesthetist also, because it is a shared responsibility there. And we document that the patient's LFT have been checked. That itself will give us a lot of strength, and all the other things that are there in the consent. These things help us in preventing a lot of adverse events. So we should be taking it seriously, even if it is not required by the hospital. That is, they haven't gone for NABH. It is in your interest to follow the preoperative checklist in a religious fashion. And if the hospital doesn't have it, keep a copy with you and start going by the checklist. That improves the safety a lot. It takes hardly 2 minutes to follow this, that all the things have been done. It is not like just ticking there. You just see that these steps have been followed. It helps us in making us better practitioner. It cultivates a very good habit and make us a safer anesthetist. And to address these challenges, EHR adoption is the first and foremost, which is going to solve a lot of problems, because most of the electronic health records will have a structured format in that, so that like the checklist, a structured format always helps us in preventing us from forgetting 1 or 2 essential steps. So adoption of EHR system helps us in documenting a lot of cases. But EHR, again, as I have told you, there is it is a very varied kind of thing. It is different from each hospital. So that is one thing that needs a solution, which I am going to talk about in the next slide. There are no standardized protocols, hence it is our responsibility that whatever we do, the protocols are to be standardized. That this is how I am going to take the consent. This is how I am going to do the pre-op checklist. This is how I am going to do the intraoperative record. This is how I am going to do the post-op record. And wherever you go, wherever you practice, please follow the same steps. And that helps in making your practice more safe. And when a dispute arises or when there is a medical legal issue, these are the things which are going to protect us. And training your assistants, if you have a technician help with you, if they could be trained, they could help you a lot with the documentation so that your workload comes down. But finally, we have to verify and sign that. And emphasis on legal education in all the places that you work, to tell them that this is the gravity of the situation. It is not a simple hemorrhoidectomy. It is not a simple DNC. Anything could go wrong at any time, even if it is a grade 1 case. We have to be in our defense at all times, because times have changed. It was not like in the 80s. Once we have come under the Consumer Protection Act, obviously any trivial thing could be blown out of proportion, and even if we win the case, we might have been to be dragged, because most of the times the district forums usually award it to the complainant. To prove it right, again, we have to deposit the award, half of the deposit of the award into the forum, and then go for the state and for the appeal. So the process itself is so convoluted. Luckily, professional indemnity is helping us a lot in these things. But unless we educate all the people who are involved in the patient care process, it is very difficult for us to follow all the steps in the documentation. So awareness in your surroundings is also equally important. And finally, documentation is just like an insurance policy. You feel that it is a wasteful expenditure as long as you are paying it. But once the claim comes, the returns are almost like 100-fold. So please invest in your documentation a bit, because it is the thing that is going to save you in the future, and it is going to make you practice in a more safer way. And again, standardization and streamlining of the process is something which, and always allocate some resources for your documentation. Like if I am earning 100 rupees, at least 2 rupees should be going for my documentation. That is a professional expenditure, just like what we invest in our kit, emergency kit, and what are all the things. Sometimes we may invest in our monitors or in our hospital. Similarly, documentation also needs some amount of investment that makes your life much more easy. So these are all the resources as far as I know that are available right away in India. The ISA app itself has a lot of help that is there, in which you can go through what are all the documents that are available, and if you want to download the documents that are there in the app, and you can upload the things also in the app. And Medjusis app is also a very beautiful app where it will give you a lot of insights into your practice and auditing, etc., so that you can improve the quality or you can benchmark your practice. And finally, coming down to my product, because this is something which I co-developed with one of my developer since the last 2 years. This is something which is new, and this app solves a lot of the problems that I have addressed previously. Because it is cloud-based, you can access it from anywhere at any time. It is a web-based app, so you don't need to download an app. You just type in the the web ID, and automatically you get directed to the site. And it can be accessed on the phone. And it has got a beautiful risk stratification. So that is, you don't need to memorize what should be the risk. You just fill out the PSC form. It is pretty easy to do. Automatically, you will generate a consent, which gives you what the surgery is, what kind of risk the surgery entails, what are the usual complications for that surgery, what the anesthesia is, and what are the anesthesia related complications in percentages. That is, so this is an ISA grade 3 who had an MI recently. So what are, it would be a 10 to 15% risk of major adverse cardiac events. Like all the indices that are there have been integrated in the back end into a matrix, so that you get a percentage wise of risk stratification, not just an odd number. It is an evidence based number. So you don't need to compensate the risk or undercompensate. You can just state the facts because it will be available right on the phone, and the consent form can be signed on the phone itself. It is so easy, and it gets automatically stored into the. Suppose your hospital has an EMR. Still, this can be integrated into the EMR by a simple process called as robotic process automation, where you don't need to integrate with the whole EMR. You just go in use the app with a login ID, like you just do in the hospital, so that the app takes the relevant documents from the EHR, populates your PSC. That also becomes easier. You don't need to fill multiple things. Suppose in the PSC you need to document the ECG, etc. You can just take a snap. It also gets loaded into the app. So, and in development, we are trying to do a thing where you can take the data directly from the monitor and populate it into the intra-op and the post-op records. And all the documentation is NABH compliant, so that at least some level of standard you can guarantee. And HIPAA compliant thing, this we are already, this is a US based product which has been adopted for our Indian environment. So the security features also have been taken care of. So this is what I was trying to tell you. Please do use it, and maybe it will make your life a bit easier because it is on the phone. Everybody carries the phone. Thank you.
Thank you, Dr. Shyam. It was a very elaborate lecture on consent, exclusively on consent. Thank you. There are a couple of questions. We will take them after all the talks are completed. Sir, Dr. Pankaj Gupta, sir, any comment?
Yeah, Dr. Shampri, that was a nice talk. I feel documenting your communication with the patient and communicating your documentation is very, very important in today's practice. And whatever lacunae that you have mentioned, all these have been taken care of in the updated guidelines, which we have already, I've already submitted to the National GC. In the next few months, probably they'll be released by the National ISA. So it's good that you have come out with this app. It will be good if at a personal level later on you share the details of the app with us. So maybe some of us can start using it and let's see how utility it is for all of us. And I feel one more thing, I feel surgery can be minor, but anesthesia is never minor. This is a very strong statement that I would like to give, that the surgeon usually tells us, "Hey, chota sa case hai, just finish it off." But no, anesthesia is always major. So always treated with a pinch of salt when any surgeon is being so casual about it. Thank you. Thanks a lot, Dr. Shyam. That was nice. Very nice.
So we will move on to the next topic. The next topic is redefining private practice, my perspective. The speaker is Dr. Guru Prasad from Gadak, from Karnataka. Sir was a freelancing anesthesiologist for 10 years. After that, he shifted to critical care and started Chirayu Critical Care at his place in Gadak. So he developed a passion in critical care and completed fellowship from College of Critical Care Medicine, and even he finished his European diploma in critical care. Now he is pursuing European diploma in eco, I think. Sir, I invite you to
Yeah.
please present.
Yeah.
Thank you.
Can Sham sir unshare his?
sharing.
Yeah.
Trying to do that, sir. Yeah. Pause share.
Maybe Guru Prasad sir can override it. If you start share,
Yeah.
it will ask
This,
if you.
yeah. Okay. Yeah. It did. Okay. My screen is seen.
Yes, sir.
Yeah. Okay. I'll just start. Yeah. Good evening, everybody. At the outset, I thank ISA for giving me this opportunity to address you all on redefining my private practice for years. So this image speaks a lot because if you have to reach a particular goal, it's not a straight line. It is zigzag, and you will get many ups and downs in your profession, in your life, and the whole thing is how you overcome this zigzag events or whatever you say. So my overview is, I say that how I started, what were the expectations of people, what were my challenges, how did I solve them, how did I move to my second innings, how teamwork makes a difference, and how I came from I'll not use the word we, it's a teamwork, came in front of the screen, what were the personal challenges and some conclusions. Okay. So in 1994 May, exactly 30 years from this month, I arrived in my town Gadag in North Karnataka as a dashing young professional full of enthusiasm. So I thought over the time I would be the greatest of all times. But what happened next was history. When I came to my town, there were 2 senior anesthesiologists already practicing there. And whenever calls used to come, naturally, I was a third choice. I would have been a choice only if they are out of town or they are busy. So with this, I would like to convey all the younger anesthesiologists, yes, you come to a place, you start your private practice. Please have patience. So please have patience. Yes, we know that you have qualified, you have come to a new place, you are enthusiastic, but you have to wait for your turn. And same for the seniors also, because now you know why you were third in call. Because now if you are practicing, you are going to a regular hospital and one more person is called, you know what's the feeling. So it's for a lesson for both seniors and juniors. So when time comes, you will be called. And before these 2 senior anesthesiologists was there, I have heard stories of the surgeons giving anesthesia and doing the surgery. If it is done even now, it's a crime. So when I went for my first case, this is what I was given to secure an IV line. And I have done quite few major cases on this. I used to start the IV line, put a 8-shaped bandage onto the hypodermic needle, go wash, give a spinal, and when the patient was turned back, there would have been a big swelling already, and now I start again. There will be hypotension naturally. I am a beginner. I don't know how much dose of local anesthetic to be given. So again, the patient is in hypertension. I start searching for a vein. Then slowly we graduated into scalp vein set. One of the surgeon told, when I asked for 18 gauge scalp vein set, the surgeon told that whether it is 18 or 22, it is the same. I had to keep quiet looking at his knowledge. Slowly the cannulas came and we were more comfortable. So what were the challenges? So basically availability of oxygen. So if oxygen was there in the hospital, then I felt like I was traveling in a Volvo AC bus. Okay. And if there was an anesthesia machine, I thought I was traveling in a A380. Okay. So that was the pleasure we used to get if we saw that oxygen and anesthesia machines were there. So most of them told that our seniors used to do cases without oxygen. They made use of the 21% oxygen in air. And I also was shocked to know when I went for an tubectomy and I asked for a line, they told the previous anesthetist used to do tubectomy with spinal, under spinal, without an IV line. So you know, when qualified people make this mistake, that is what the surgeons take into granted. So convincing the surgeon to upgrade was another biggest challenge. And help, you are the only person around the patient, starting from IV line, preparing the drugs for your GA, intubating, fixing it to the ambu bag, or the anesthesia machine. So you never used to have help, and unfortunately there were no qualified nursing staff. Basically, the nurses were supposed to be domestic maids. They were made to wear white saris, and they were the nurses, and we had to work with them. So financial constraints. Whenever we asked the surgeon, we wanted something like a anesthesia machine, or instead of ether, we wanted halothane that time, and now isoflurane. Their only answer was, patients are poor, they are not affording, this is all we can give. But I was surprised to see such luxury cars in front of their house, which was bought after they earned the same money from the same poor patients. So they could buy a luxury car for them and build palatial houses. But when it came to upgrading the hospital, there were financial constraints and patients were poor. Naturally, government services were poor that time, but it slowly improved. Case load was high. No corporate setup that time. We were all individual nursing homes, and insurance facilities were not there. And these were part of the challenges. Unfortunately, I had 2 mortalities in my first 100 cases. Not because I did something wrong. That was because of purely the facilities were not there to deal with the complications. I had to anesthetize an obese patient. Though I told I wanted to do the case under GA or under spinal, the lady who was a relative of a nursing staff told that she wanted GA and she never got up. Okay, this was a time either I had to fight with the system there, or flee. But if I had fled that time, then the standard of anesthesia would have remained the same. So I decided to fight. So then came how I started overcoming all the challenges. So I started convincing the surgeon to upgrade, and in case he didn't upgrade, what I did was I cancelled that surgeon. So no going to him. Whenever I used to get a call, I used to ask whether you have upgraded this. Then if he says no, I used to say, please carry on with some other people who would like to come and take the risk, but I was never to come. Because for me, safety of the patient was first. Then there were few sensible people who agreed to upgrade. And for them, what help I did was, I used to contact the equipment distributors and suppliers, then bargain, make a deal, and try to get them the equipments at the best price. So there were talks telling that Guru Prasad used to make money out of that, also getting commission, which I didn't mind, because for me, patient safety was first. Then I started learning regional anesthesia, which really bailed me out from many situations of making dealing with high risk cases. And whenever patients were not ideal for general anesthesia, I think regionals really helped me. It also, the post-op monitoring would have been very easy, because the patient would be awake even post-op, and the monitoring used to be less. And it definitely served the purpose of being more economical. Then what I had to make more changes, like I overcame whatever the surgeon told. Then I thought, why not I buy the pulse oximeter? I bought a similar pulse oximeter of MCO company, which costed around 35,000 that time. I made a loan and bought it, then started using it on patients. So that time I used to show the surgeons what is oxygen saturation and what happens when the saturation falls. And I told them that before the blood becomes dark, this saturation will fall and I can act. So this is how I was trying to convince. If we are also loggerhead telling that if he is not going to invest, I will also not invest, but I'll put the patient into unsafe zone, that is wrong. Then slowly, I was very much interested in automated record maintenance. And I used to carry a laptop with and special software where I used to do all the record entries. Then what I met a person in a conference who prepared this small module to this laptop, which connected to the patient, and I used the laptop screen as the pulse oximeter screen, and this is how I upgraded myself. Then with upgradation, we did cases. We used to even do cases like pheochromocytoma, but it in a proper way with proper intra-arterial monitoring and with use of CVP. So finally, what happened from 1994 till 2015, I did practice anesthesia, but a time came when I had to change. So that's what it said. Just when I thought I had learned the way to live, my life changed. And why did it change? I was a sports person, regularly going to the stadium, and I used to meet many youngsters who used to practice for their future or whatever it is, for their passion. I knew one guy who was a 22-year-old footballer, who was a university player, who underwent appendectomy in a private nursing home. After 2 days, he developed sepsis and came to one referral hospital where I used to work. At induction, he crashed, but somehow we resuscitated him. Then we put him onto ventilator. So most of the people think that ventilator is the end of it. We put him on ventilator, but he didn't survive because he went into all the ventilator associated pneumonia, and we lost him. This was a time I felt very shameful. If we can't save a 22-year-old patient, what are we doing? And from that time, this thought of doing something good for the society came. Then, if at all I had to jump onto that, there were few issues which were coming. I was nearing 50. My children were growing, and we had to decide education for them. Finances was definitely bad. I didn't have that good knowledge to manage critically ill patients. And that time, when you wanted to start, you know who the true well-wishers were, because the surgeons whom I was going knew that now I will not come for their cases, and they started behaving very hostile. And I had to sacrifice many of my passions. So how the journey began? These two young anesthetists approached me, telling that, sir, shall we start critical care? I was quite happy. I wanted to join them, but being a partner with two females, I thought I have to be little safe. Then I pulled out Dr. Mali, and then that was the time in 2015, Team Chirai was born. And why did they approach me? That is more important. Most of the youngsters are scared to reach the seniors, because the seniors feel that when a newcomer comes, a senior feels that they are competitors. Never treat them as competitors. Please treat them as colleagues. Only then the juniors will be close to you. So that is the reason they came to me. In fact, I used to go to their OTs and teach them regional anesthesia. And many of the surgeons discouraged me. They told that if you go and teach all the youngsters, people will stop calling you and call them. Because I knew that I am not a person who is going to live for 100 years. And even if I am not there, the system should go on. So the best thing is, when you have got a knowledge, you have to disperse it. So even if somebody far away from you, after you have taught saves a patient, indirectly the blessings will come to you itself. Then I confirmed the intentions from my partners that whether they were interested to really give quality service or make money, they were for service. And even till today, we are the same. Making money was not our goal. Profits would be the byproduct of our honesty and commitment. And this is our hospital, which started in 2015. We follow all the standard protocols, which is followed in all the big places or in a foreign country. And we save a lot of ill patients, sick patients. So I had few myths about critical care, because I thought that I could intubate and secure good lives and do percutaneous tracheostomy. I would be a good intensivist, but that was wrong, because I had lost most of the clinical touch. I couldn't do differential diagnosis. I even remember days when we started our setup, that if a patient came with stroke, I used to make a diagnosis of stroke, but I didn't know how to manage. I used to run to the doctor's room, read and come back and again try to handle them. But now it's not the case. Within 5-10 minutes, all the decisions are made because we went through the kind of the critical care. So I had to go back to basics. When we did anesthesia, critical care was not a separate department. And the concepts were not there. And I had to go back to reading acid-base disorders, water and electrolyte. I think I'm sure that you also didn't read this during your MBBS days because they were very boring topics, but they are the main topics in critical care. Then I had to learn how to interpret an ABG. Antibiotics, invariably, what we anesthetists do, we give the antibiotics, whatever the surgeon tells. I think all of them agree. We never ask why you are giving cephalosporin or an aminoglycoside or something like that. So once the surgeon says you give zone, you give zone. So most of the times we don't know what zone also has. So now younger generation are quite intelligent, but that was my standard of knowledge. So I had to know more about cardiology, neurology, pharmacology, microbiology, ECG interpretation. Yeah, we do to see a few T wave inversions and postpone the case, but it is not the case. It's not the thing. There's a lot to be seen in an ECG, and especially when you sit in a casualty, as a patient comes with chest pain and you see a ECG, you are happy if you see a ST elevation because you know the diagnosis. But if it is normal, it is very difficult to send a patient home who has come with a chest pain because there are a lot of protocols and you may lose a patient. CT MRI interpretation, yes, we always used to pick up the report given by the radiologist, but that is not the thing now. You have to learn to read a CT MRI whenever you are an intensivist. Learn bedside ultrasound, which makes a huge difference. I had to attend refresher courses, CMEs, then invested in textbooks. As Prashanti madam told, I did do my fellowship in critical care. Just for 3 years back, I completed my European diploma in intensive care, and now I am pursuing my advanced critical care echocardiography in 2 places. So only if you update, you can do the best. I learned little more about using ventilators, doing lung and ultrasound, point of care ultrasound, which makes a huge difference in managing patients. So I used to be a lot of stressed when I used to handle cases initially, but once my knowledge base improved, I became very stress-free and I am more relaxed now. Just a word about all the private practitioners about owning. When you always feel that the hospital owners don't pay you well. My concept is totally different. If the charges are fixed for a cesarean section of 2,500, if they give me 2,500, I'm happy. I take it back. Please don't look back and see that the hospital charged 1 lakh and they gave me 2,500. Instead, you should have asked 5,000, and if the hospital should give 5,000 to you. So the hospital has got a lot of its own headaches to manage, and that's proportionately they charge for that. Okay, and you have to have a good teamwork when you have a hospital. Then manpower is always a challenge. Training your staffs is also very important. And the best part is when you're working in some other place, if you want a pulse oximeter or a multi-monitor, you have to ask the management. But by owning the hospital, you are the decision maker and you can do the best. So this is just what I like to say is, if you are being paid your charges, forget what the hospital does. So as they always say, there is no gain if there is no pain. I became richer by knowledge, but poorer in my pockets. I had times when banks turned down my loan applications. I had to think twice when I had to buy mineral water when I was traveling. Even your loved ones look different. You in a different way because they were expecting to live a lavish life because his father is a doctor, but I was a different one, and they did support me. So what I achieved, my goal in life is always change. So change is the only constant. I keep on changing. Hopefully this will be the last change in my profession. I don't have anything more to change, I think. Then I was very happy that I was giving back to the society, the place where I was born. I was serving the people. Then best is when you start reading and start moving with younger generation people, you feel young. You never grow old. So that was one of the thing I achieved. Then roles were shifted. Like we always say, as anesthesiologists, we are behind the screen. No, and being an anesthesiologist and intensivist, you will come in front of the screen and you will be appreciated. Society started recognizing you, and we started achieving our goal of saving lives. Did I deserve this hard time? Yeah. It was very tough times. Most of the time, believe it or not, earning from 1.5 lakh rupee per month. Sometimes, some months we didn't take money to our house in spite of our own hospital, and for long we took only 25,000. But God was with us. We didn't have any major financial crunch at that time. But now we are doing well after 9 years. So good time comes, will come, and it has to come. And as they say, tough times never last, but tough women and men do. So the panel should say that whether I took a right decision at that phase of my life. So what are the rewards of working in a periphery? No hustle bustle of big cities. You get good quality of life, clean and non-polluted air. You get recognition. Gratitude is shown in a different way. We don't get greeting cards or bouquets. People give us fresh vegetables and nuts, and even we had the privilege of getting this sheep as a gift, because this patient was operated in some small hospital for gallbladder, and there was a hepatic injury. The surgeon packed the abdomen with box and shifted to our place, and the patient survived. And this is what he gave as a gift to the surgeon. And so that's how they are so nice. And in our place, we are still respected as God. Though I tell them very on the face that we are also human beings. We are just trying to use the knowledge, but God is there outside in the idol. You can go and do namaskar or pray at the that idol. So that's what they say, that success takes some time. So now I am back to my passions of having a pet and enjoying with him. He is joy, and he gives us joy every day and night. Then I go on long rides on my bike with the money which I have earned with very good bikes. I lead a very good hobby of riding. Then even I hike on Himalayas. This was about few months back when I did a Kashmir Great Lakes. So passion does come in the way. For that, you have to work hard. What I tell the beginners is, no, don't try to become like me on day one. I have struggled for 30 years to come to that level. Okay, so attitude matters. It is a very small thing which will make a big difference. Don't have mind blocks like, no, the surgeon will not do that, surgeon will not do this. He will do it. Try to convince him. Be ready for challenges. Don't try to be in comfortable zone. If at all you have to progress, be in a uncomfortable zone. Don't give excuses. Be proactive. Don't procrastinate, and always try to update. So what is success? Success is not only about having more money and higher social status. It is about being less stressed, less worried, and more peaceful and happy. So what I learned, success comes late when you practice ethically. Success comes only when you are committed and passionate. Never betray your conscience. Counseling is the key to success. Why I'm telling you this is, when we plan to start the ICU, there were many people telling us that, no, why you are starting all this? You are such a casual guy. You got so many passions. There will be a lot of fights in the ICU. Patients will not pay. They'll fight with you. I'll tell all the youngsters here, don't be scared of starting an ICU. What you have to do is a proper counseling. If you spend 10 to 15 minutes in the day and 10 to 15 minutes in the night, then no questions will be asked. In 9 years, I think 2 or 3 people have created some problem, but we have given back to them and they have run away. Okay, so counseling is very, very important. And you heard about documentation too. So put a break to comparing a freelancer with a hospital owner. Okay, I think most of the conclusions are same what I spoke because of short of time. So how we have to live as if you were to die tomorrow, but you have to learn as if you were to live forever. And everybody is not the same, so people may hate you for being different. Okay, like me, changing the field totally at that age. but so people may hate you for being different and not living by society standards, but deep down they wish they had the courage to do the same. So thank you. So if at all you have to reach to see such a beautiful destination, there are lots curves and uneven roads to reach, and only then you can reach such heavenly or destinations. Thank you, one and all.
Dr. Guru
Thank you,
Prasad.
Guru sir.
Yeah, yes, sir.
Yep. That was a very stimulating and very emotional talk, I would say. I feel you have taken all of us back into history, and all of us have remembered our initial days in practice. And I feel it's very important, as you said, to welcome the juniors and encourage them and guide them. And
Yes, sir.
one big thing which I message I wanted to convey through your talk is it's never too late in life to start. At the age of 50, if you can start your own ICU, it definitely is a great thing to start, sir. I feel that was a very, very, very nice talk right from the heart. Thank you, sir. Thanks for a nice
Thank you, sir.
talk.
Thank you. I'm extremely sorry I took 10 more minutes. I think I thought I'll finish in 14 minutes.
I just said that
Extremely
I could see
sorry.
the emotions there. That's why we didn't stop you. No problem, sir.
Thank you, sir. Thank you.
Yeah, thank you.
There were very lovely comments in the chat box for you. Maybe
Yeah,
you can just peep into them. Not of wasting much time. Again, we move on to Nendra Reddy. Am I audible?
Yeah, no.
Hello?
Yeah.
Am I audible?
There was
I'm
a small
sorry.
break. There was a small break in case your link gets cut. Just switch off the video. Okay.
Okay, sure. So I think someone needs to mute. Okay, right. Thank you. And now we move on to our next speaker, who is a very dynamic anesthesiologist, Dr. Arunendra Reddy from Hyderabad. Dr. Arunendra is the treasurer of ISA Hyderabad and also a director with Plexus Anesthesia Services. Dr. Arunendra is also director of Raghavi Hospital and a good friend. Dr. Arunendra is going to cover a very, very important topic that possibly is every anesthesiologist's nightmare, and that's unanticipated death on table. So I'm sure a lot of people are waiting to listen to you, Dr. Arun, of how one would deal with such a situation in a nursing home. So over to you, Dr. Arun.
Thank you, madam, for that introduction. Good evening to all the seniors and my colleagues of anesthesia fraternity. Just let me share my PPT. Yeah. So as madam was mentioning, today my topic would be something which every anesthetist is very uncomfortable with. So death on an OT table. So what next? Before that, let me go for a simple case scenario where you are sitting having some coffee in your family, having a good time. Suddenly you get a call for a surgery, and the hospital reception says that it's a emergency surgery planned for an 18-year-old male. It's like mostly it's a grade 1. All investigation seems to be normal. The surgeon is ready, OT is ready, and all that has to be done. You have to come and give the anesthesia. So you may ask, what is the emergency here? It's a young patient, torsion testis. So you go there, you give the anesthesia, and the case has started. You get if the hospital has a casualty down after around 15-20 minutes, you get a call saying that there is a problem in your in the ICU for a patient, and they ask you to just come. So you just go to the ICU, you see the other patient, you treat the patient. After 10 minutes, you get a call or shouts from the OT saying that the patient in the OT is not having pulse, patient in the OT is not responding, and BCG is flattened. So you go to the OT, you see that the patient, you try to, the patient is in arrest, you try to revive the patient, you do your CPR, you do all your required protocols, but still there is no response. You have done it. It's almost 1 hour. There is no response, and all that you can do now is declare that the patient is dead. So this is a very, very scary scenario for any anesthetist, whether it's a junior or senior or whoever it is. You are alone, you are the only anesthetist there. So what goes in the next 1 to 2 hours can actually save you or get you into trouble. Coming to the incidence of deaths on the table, you see most of the ASA1 patients, the death rate is very less. It is 0.5 to 0.8 per 1 lakh surgeries. But it has been seen that in emergency scenarios where the patient has not been properly checked or no PAC is done, the emergency surgery death rate is almost 80% if you consider death on table. Similarly, ASA grade 3 is 1.8% mortality when compared to grade 4 patients where the death rate is 9.4%. So most of the times, since we are all well equipped and we know all the protocols, cardiac arrest can be reverted, and most of the cases the patient does come out from the arrest scenario. Most of the common surgeries where you see such incidents are cesarean sections, hysterectomies, minor procedures like MTPs, and sometimes laparoscopic surgeries. Okay. So now the scenario is the patient is dead. You are the only doctor, only you know what has actually happened in the operation theater. None of your team members understood what has happened because you are the anesthetist and you have given the surgeon anesthesia. So it's like a scenario where there is a lockup death in police custody. If you take anesthesia, it can be during anesthesia, but it can be an unrelated cause, or it can be a very anesthesia related cause during the procedure. You see what are the causes unrelated to anesthesia. It can be ASA grade 3 to 4 patients, patients with valvular heart diseases, sudden MI on the table, surgical shock, and accidental burst of an aneurysm, and a large vessel damage. But if you consider anesthesia as a cause, most of the time it is mishap due to non-intubation, or there will be a lot of technical mishaps, which may be equipment failure, wrong drug administration, there may be oxygen failure, or there may be a wrong anesthesia agent given, or there may be a cardiac respiratory complications. So now, when a patient has died in the operation theater, it's a situation where you least expect. You don't know, you're just blocked. You don't know what to get out, how to get out of the situation. It's completely one-man show. You will be in a haphazard way. You may not have followed the guidelines, as there are many other causes like workload or tight schedules, or sometimes you don't want, you are very stressed, but still you don't want to lose a case. It may be due to a competition from your peers. So you are in a situation where you need to come out of it. So what can be done at that point of view? You have to keep your calm. First, try to call for help. Ask the surgeon to close the surgical wound, avoid leaving anything in the wound. remove unnecessary tubings to the patient, make sure that you calculate what is the urine in the bag. Then you decide to go and first inform the attenders as to what has happened. So shall we shift the patient to the ICU and then inform the relatives, or it's a big question. You have to know whether the relatives are seeing you, whether the relatives are just outside the operation theater. You need to gauge the situation, whether you want to shift the patient to the ICU and then explain to the attenders what has actually happened, or already since the patient has died in the OT and you want to comfort the attenders, then you can declare on table death and explain to the attenders. Before you go out, you make sure that the drugs that you have given, the ampules, the syringes, everything are stored separately. You don't, in a haphazard way, try to clear off the OT. Make a proper chronological documentation of your PSC notes, free of fitness, anesthesia records, nursing notes, resuscitation notes, and also be in sync with the surgeon. Always be in sync with the surgeon as to what his notes are and what your notes are. So make sure that you are working as a team in the hospital. Make sure that you inform the reception of the hospital. Ask them to contact the local police. If you call to 100, which normally all the calls are reported, that is even a better proposition. Inform them what has happened, what is the incidents. Make sure to inform your local ISA, IMA, and other organizations which you are trying to organize at your level, and trying to seek medical legal help. So always remember, any surgical case, the surgeon is the main person who is responsible. So keep in mind that the surgeon should be informed as to what you are doing step by step. Call for your fellow anesthetists so that they would be of support to you. If there is, from the hospital side, any suspicion of equipment failure or malfunction, make sure that you keep a note of it and get all the evidence that the machinery has not been functioning properly. As I said, it's always better to inform the surgeon, then the police, then your colleagues. Some hospitals also have the security people, bouncers or security on board. So they also have to be informed that there is an incident in the operation theater, and they should be ready to face any incident. Being an anesthetist, it is always important that you have some good contacts with the local politicians and local police also. Try to know who are the patients. Try to see if you have a common connection, if there is a common friend among them. Always see who is the patient, see where he resides, is he in the local area, or what, or if you can find a common link. So as an anesthetist, your liabilities when you are in this situation. So your liabilities come whether you have properly investigated the patient before going for anesthesia. So make sure you have all the PAC notes written, all the investigations done, and whether you have taken proper consent for the surgery and what type of anesthesia you are giving, whether you have taken high risk, moderate risk, or low risk for this particular surgery. Explain to the patient attenders what type of anesthesia was administered and what is your experience in giving that type of anesthesia. Always make sure that you tell the attenders that the hospital is well equipped with all the protocols. You have tried to resuscitate the patient. you whatever equipment is available, make sure that the attenders know that this type of surgery was done in this operation theater and the operation theater was equipped with all the equipment. So where you cannot panic in this situation. Yeah, it's a very stressful condition. Everyone is looking at you, all the OT staff, all the nursing staff, the surgeon, everyone just looks at you because you are the person who have induced, you are the pilot of the plane here. So you, even though the surgeon is there, always it is your responsibility to make sure that you are.
Hello.
Hello. Yeah. So always call for your friends, you call for your relatives, make sure that you have support. Make sure that you have 2 to 3 people around you. Never blame at that situation the surgeon or the hospital. Equally, don't allow your staff to go out of the OT, talk to the attenders, tell what it is you and the surgeon who only should go and talk to the attenders or to anyone else. Nothing should be leaked out of the OT at that scenario. There should not be any discrepancies in the record. There should be a single case sheet because that's going to become a MLC police case. So before the police arrive, you have to make sure that your case sheet is complete. Make sure that every note, every detail, every timing, what are the drugs that you have given, what was the response, what were the vitals, and everything has to be noted in the case. So as the time develops, there will be normally immediate responses and delayed aftermath. If you see the immediate responses, immediate complications that you will be facing, the most toughest thing is going out, facing the situation, braving yourself in front of the attenders and breaking the news. You have to ask, respond to the questions, fear mob violence, handling police inquiry, medical legal issues, arrest, bail, and so many things. Similarly, the long-term effects may be damage to the reputation of as an anesthetist, loss of self-confidence. There will be a lot of stress during this period. There may be court cases, there may be compensations, and a lot of amount involved. So how do you break the news? Stay at the hospital, never run away. First thing, you have there was a problem, you have to face it, you can't run away, you have to be with the surgeon. Don't allow the surgeon to escape. Make sure that the surgeon is available and as well as you are available at the place. Be more compassionate. Yeah, it's definitely a big issue when there is a life loss. Try to take the patients away from the attenders, away from the mob. Make them comfortable. Don't hide the facts. Be ready for extreme actions. And there are certain like protocols where you can, there's a spike protocol, like the setting where you want to announce the or break the news. It is choose a private place away from the crowd or shouts. Make sure that you have your staff know what are the attenders thinking about what actually happened. Have they demanded for more money? Have the reception billing people talk to the attenders and they have asked for a huge money to the patient before the surgery? Whether the patient is actually happy getting operated in this operation theater. Ask the attenders to question you, invite them to ask questions so that you can explain in your knowledge and see and make sure that you are quite knowledgeable to answer their queries. It's an emotional state, always try to respond to their feelings and summarize everything. So actually what started, how did the case start, what happened? Don't try to give the loose ends. Don't tell the attenders that you were out. Don't tell the attenders that you are attending another case. make sure that you tell that the patient was attended well. We have all the staff and the monitors in the OT, and it was a sudden incident that has happened. So when you are communicating with the attenders, try to always keep your surgeon beside you. Maintain transparency as far as your anesthesia is concerned. Answer all the queries. Don't look into the face of the eyes of the attenders. Try to answer their questions with confidence. When you show more concern about the incident, definitely the attenders are also going to sympathize with you. That's how emotions work. And remember that since all these procedures need further investigation, and probably post-mortem is always the main option. So you have to make sure that the attenders are explaining that this patient will go for a post-mortem. If you, how do you identify the patients who are, may become aggressive? The stamp protocol where, if the patient starts staring at you, there is prolonged hearing, they are not talking to you, but they are giving a silenced, glared look to you. The other attenders are talking to you in a harsh tone, who are arguing about different things, that the staff is not good, equipment is not good in the hospital. A lot of anxiety in the attenders, and there are a lot of attenders moving in and around the hospital. So all these things have to be taken into consideration. You should have the hospital staff who are checking all these things, to whom they are calling, whom they are mobilizing. The attenders are they receiving the news in a way that you are anticipating, or it is going out of your control? So you have to simply listen calmly to the attenders. They would be scolding, they would be threatening you, they would be giving all types of scoldings to you, bad mouthing. You have to listen calmly. That's very important. You cannot counter them with your knowledge or with unnecessary provoking them. You have to give them privileged treatment. Make sure they are always given the right to shout on you, venting their anger on you for some time, and then slowly try to encourage and solve the problem in your way. So always try to control your emotions, your anger. Handle the case directly. Don't allow middlemen to come and start talking about you, because middlemen really don't know. Even you have called your friend anesthetist. Make sure that you are always there when you are talking to the attenders or when you are talking to the concerned police. So remember that aggression is not the problem, it is the outcome, which is very important. Your aggression will only cause more problem to you than solving the problem. Coming to the mob violence, always be prepared to call the police for protection. Don't think that avoiding the police may help you. No, it is always important that you inform the police that a situation has happened. It was not self-inflicted or wantedly done, but it was a misadventure which has happened. And so you have to make sure that you have to inform the authorities. In fact, to avoid the fear of mob, to tackle the mob violence, you better have the numbers of the local police commissioners, IMA and ISA office bearers in your operation theater or anywhere accessible to you. So make sure that if it is a death linked to abortion or death on table or death that has happened when after shifting the patient immediately in the post-operative period, all these times it is very mandatory to inform to the police. So the attendants may ask, so why are you calling the police? What is the need to inform the police? Yes, police has to be informed, Panchnama has to be done. All the facts have to be noted by the police and acknowledge that you have informed them, and they will in turn start negotiating or talking with the attendants. Always involve the surgeon because surgeon is the first point of contact with the patients. So even tell the surgeon to make sure that he also is in sync with the police. So here, most of the time, what do the attenders, accuse the anesthetist? The attenders may accuse the anesthetist that the death was due to mismanagement by you, malpractices. The anesthetist was not well equipped to handle the case. There was no proper equipment, or he must have most of the time given an overdose of anesthesia. So most of the time, the attenders always tell that the death was due to overdose of anesthesia. That's the reason the dosing of each and every drug, the broken ampoules, always have to be preserved and kept in the operation theater, and they have to be noted during the procedure with the proper timing. So always there are certain cases where, like in the Karnataka High Court, a case of death on table was considered where postmortem was not done. So when postmortem was not done, later the court had identified that the postmortem would have actually identified the actual cause of death, and as a result would have been some relief to the doctor as to know actually whether the cause was due to negligence or due to some other pathological findings during the postmortem. When you are, once the police comes, when you want to hand over the documents to the police or to the patient, make sure it is complete. You should hand over the official documents only to the police, and if the attenders want the report, there has to be a proper application for that. You can definitely hand the Xerox of the case sheet to the attenders. Make sure that you're not complicating your scenario by adding some adverse findings of your own, cutting the case sheet and rewriting. All these can always be avoided. Also make sure that your OT nurse staff has checked the WHO PAC chart and they have signed. All the investigations have been done properly and the consents have been signed beforehand. So these are very important before you hand over the document to the police. And if possible, trying to get as early as possible in contact with the medical legal expert or a consultant who can actually guide you, your seniors in your area who can make sure that your case sheet is perfect and up to the mark and avoid any complications in the case sheet. As I was mentioning, there was an emergency case. You just went into the operation theater, you gave anesthesia. And then there is no way you can explain the cardiac arrest during anesthesia. So every case, PAC is mandatory. Even though you are entering into the operation theater, make sure that you see the patient at least once before entering into the operation theater along with the attenders of the patient. Make sure you document your PAC. In that PAC, you have to have all the age, sex, occupation, address of the patient, date and hour of visiting the hospital, evidence of informed consent, brief history of present illness, family history, and all the other things like what are the objective findings and the subjective complaints of the patient and the diagnostic report. Whether you have given proper pre-operative instructions, complications of medical diseases if the patient is having. So all and as our previous speakers have explained, PAC with all the documents is an absolute must if you are to face any case. So whatever case, whether it's a simple one, ASA 1 or ASA 4, make sure that PAC guidelines are followed properly and strictly. So pure records, pure defense. No records is absolute zero defense. So, like Dr. Krishna Prasad was the state of Karnataka, the court has noted that there was no record of continuous monitoring of pulse or blood pressure which was found in the operation theater. The surgery was starting at 9 a.m. The notes were only written at 9. After that, there is no clear notes after every 10 minutes or 15 minutes. So we have an anesthesia chat. You make sure that you have the notes every 10 to 15 minutes, what drugs you are giving, what is the saturation, pulse, and the BP, which are very important in any court of law. Similarly, in another case of Meenakshi Mission Hospital and Research Center versus patient Samuraj, there were 2 anesthesia records with different time of arrival of the patient, different anesthesia notes were written. As a result, since both were different, the hospital was held liable for deficiency of services. So always one anesthetist, one notes. Even if it's a team practice, make sure that the note is just followed continuously and the second anesthetist need not start a new note or write a new finding. So these deaths that most of the time happen in hospitals do come under the IPC 3048, which is death due to negligence. Whoever causes the death of any person by doing any rash or negligent act not amounting to culpable homicide shall be punished with imprisonment of either description for a term which may last up to 2 years or with fine or both. So this is the normal IPC that is applicable for death on tables. So the National Medical Commission has given some guidelines along with the MRB. So these are the need of the hour. To form district medical council boards, to form state medical council boards. The doctor cannot be arrested in a routine manner. It's a special case. Preliminary inquiry has to be done, at least for a time period of 2 weeks. If the either parties are dissatisfied with the inquiry may be referred to the state board. There can be a special pool of expert committee members in this medical board. So, okay, so scenario is there, you have handed over everything to the police. Now, can the doctor be arrested? Mere allegation is not enough to arrest a doctor. Arrest is possible if there is a gross negligence which is evident. Like the anesthetic is not available.
Hello, Arun.
Sir, yeah, I'm almost done.
Yeah, okay.
So the who can be arrested or who can arrest a doctor? It's mostly the superintendent of police or the deputy commissioner of police only who have the authority in this type of section to arrest the doctors. So finally, the long-term effects, it will be a assassination of the character of the doctor, the lowering the self-esteem and credibility, and there may be, which has been noted very clearly in many situations, suicidal tendencies also in doctors, if they are not having any support from their colleagues. So as this condition, especially when there is a problem in a hospital, most of the doctors from the outside, they always try to say that, oh, that was a normal case. Why did the patient die? I think the anesthetist has done a mistake. It was his problem. So this is where I think as a society, as a group of professionals, we should stop commenting on what has happened to some doctor and actually be more supportive to him. It can happen to any one of our colleagues or to any one of us. Always try to support your professional friends whenever there is such influence. Finally, unity and unity is what we need in our anesthesia practice to tackle such situations. To always develop safe anesthesia practices. Don't rush for any case. Try to have proper documentation. Always have a crisis management plan. Have a valid medical indemnity or insurance, and best police and IMA and politicians' phone numbers available with you. So these are the ideal anesthesiologists at work where you can avoid such complications. Minimum 8 hours of sleep, arrival at 15 minutes at least before the case is posted. Be calm, relaxed, in a comfortable situation. Don't hurry up for cases. Don't consider a competitor from a competition with your colleagues. The take-home message: proper and knowledgeable communication is very important. Always try to communicate with the surgeon, the staff in the hospital, in the OT. Make sure that everyone is alert. Make sure everyone knows what you are expecting from you. So I would end this lecture by saying that begin with the end in mind. So always before starting any case, make sure that you have a safe pathway. Make sure that you are well equipped with what you want to, how you want to travel the journey. Thank you. Thank you very much for this patient hearing.
Thank you, Dr. Arun. That was a very lucid talk, and I know you could go on and on, but we are short of time. So we will immediately go into the next this one, and I'm sure there will be a lot of questions on the panel about this. Thank you, Arun.
Thank you, sir.
Yes, thank you, Dr. Arinendra. It was a very extensive talk. And next we will move on to the last topic, that is failed regional blocks, now what? By Dr. J. Balavenkata Subramaniam, Ganga Hospital, Coimbatore. I know Dr. Balavenkat sir requires no introduction. All of you know him, but I will introduce him. He is our president, national elect of ISA National, and now he is also the secretary of WFSA. And sir is actually in transit. He's traveling from some country. He has reached Coimbatore and he will be joining us in the discussion. We will have his pre-recorded video. Sir, please play the video.
Good evening, everyone. At the outset, I extend my sincere thanks to the Governing Council member of Indian Society of Anesthesiologists National, Dr. Pankaj Gupta, for the initiatives that he has taken to propagate academics and knowledge across country through the webinars which will happen every month. And thanks to Ala Prasanthi Madam, the coordinator for this session, where the South Zone is doing this particular private practitioner forum-based webinar. The topic that's been given to me is when the peripheral nerve block fails, what we should do next. I bring to you greetings from the city of Coimbatore, and it is the city of the Coimbatore currently is marked by this iconic, the statue Adi Yogi of Isha Yoga Center. And I bring to you greetings from Ganga Medical Center and Hospital, Coimbatore. And we are moving into an era where regional anesthesia has become an inherent component of either a pure anesthetic technique or as a component of multimodal analgesia to alleviate surgical pain in the postoperative period. But as anesthesiologists, we are extremely conscious about our block working, especially when it relates to the upper extremity. The surgical colleagues consider each one of us as a good regional anesthesiologist based upon our ability to give a block for the upper extremity without any kind of supplementation, which means patient was fully conscious and oriented, but the limb is numb, and throughout the surgery, he does not have pain. And at the end of the procedure, he is awake and who is able to walk. So this is considered as a successful block. And the anesthesiologist who accomplished this are really called as successful regional anesthesiologist. So this regional anesthesia is definitely a tool in advancing the quality of patient care in the perioperative period. I wanted to speak about one aspect which was developed by late Dr. Ravindra Bhatt of Ganga Hospital when we were a very small hospital, when we didn't have ultrasound, when we didn't have a peripheral nerve stimulator, was on-arrival block to all the victims. It made a huge impact, and now we have evolved over a period of several years, and now on-arrival block is an inherent component of every trauma patients who needs emergency surgery. And even if they are not, it is given for pain relief. For example, neck of femur fractures, it immediate block on arrival. All this goes on to show it's not only owning responsibility, but also reliability. And to become reliable to the surgical team, we as an anesthesiologist have to put the interest of the patient first. And we need to do all those factors which are needed to make them pain-free. And then this regional block becomes a very inherent component. So it is our patient rather than your patient, and all of our patients should get regional anesthesia in the most appropriate way. Modern quoted, regional anesthesia always works provided you put the right dose of right drug in the right place to the right patient. And when you get a patient like this, you definitely wanted the block to work. So this could be accomplished either with the help of ultrasound or with the help of a peripheral nerve stimulator. The challenge would be when you use a peripheral nerve stimulator in such a case, you will not be able to see the end motor response like what you would otherwise see. So it becomes pertinent that you do this either with ultrasound guided or the brachial plexus is performed with landmark technique. So this goes on to prove that there is a role for an anesthesiologist to know all the three different ways of administering a block. In the absence of ultrasound, he should be good in landmark technique. And in cases like this where the peripheral nerve stimulator wouldn't work and you don't have an ultrasound, landmark technique should work. And it's also important that to get the block right all the time, the desired prerequisites are a very sound knowledge of the anatomy, to treat the possible complications aggressively, and to use the gadgets which I showed like PNS and ultrasound. And most importantly, when the block didn't work, to accept the failure, it's called what we call it as an egoless nerve block, and embark on a journey of safety. So now how to be a successful regional anesthetist? So I would wanted to quote, you begin with the end in mind. For example, tomorrow you're going to do a humerus surgery, like a shoulder procedure, and you decide to do an interscalene block. And if you are in the beginning phases, it's very pertinent that you go through the videos of either the peripheral nerve stimulator or the ultrasound and observe those videos and learn from them. And you will be sure that next day, when you do it, you will do it with ease. This is what is done by all the peak performers, irrespective of what game they play. So Mahendra Singh Dhoni would watch his opponent bowl several times the previous day, the videos of the bowler who is going to bowl for him the match next day, and he's mentally prepared to face each ball. Similarly, we need to know the anatomy, anatomy well, and we do it the previous day. And so when we put the probe or when you use the peripheral nerve stimulator, you'll be able to get the block right. So you need to mentally do the block the previous day and do it physically on the day when the patient is being posted for surgery. And this is definitely a tool which has enormously changed the way we practice regional anesthesia. And I'm extremely happy to know that many people, even in private work, have gotten access to ultrasound. Many of the hospitals, even private hospitals, have an access to an ultrasound. Here you see that very, very clearly. You see the subclavian vessel, and you will see the bundle of grapes there, the bunch of grapes there. So nothing like viewing this and getting the needle inside and putting that local anesthetic solution close to the plexus to get a 100% block. The success rates are going to be extremely high when we use this. One of the other ways to get the block right appropriately is to reach on time or reach before time. I would strongly recommend, if you are especially in private practice and you decide to do an upper extremity block and you want the block to work, you need to reach the operating room at least 30 minutes before the scheduled time for surgery. And a block room, not necessarily inside the operating theater, but in the preoperative hold, you need to create an environment, because the single most important factor that has been found to produce high quality blocks are those institutions which have got a block room. And this block room will have a very calm, quiet, very well equipped place. And either the PNS ultrasound or the landmark technique. You also have emergency cart and monitor equipment. So after getting informed consent and NPO status and making sure that you are blocking on the correct side, you embark on the journey of giving block. And I just wanted to quote an example, what an anesthesiologist would want to do. This is an example which I quote several times. So he's Mr. Anand Peter of Video Line. We were about to start a live workshop of arthroscopy at 9 a.m. He was climbing up the stairs and he tripped down and had a distal radius fracture, and that was about 8:20 a.m. So he came in with the wrist dislocation with significant pain, and he was given an ultrasound-guided subclavian perivascular block at about 8:30. 10 minutes the block took. At 8:40, reduction was done, pinning was done. And at 9 o'clock sharp, he was all set to go and do the live workshop. You still see the IV cannula in him, and you see the sling there. So this should be the precision, and this should be the dream and the goal of every anesthesiologist and private practitioner. And here is, he did the work. And then he was at the end of the live workshop, he was all set to go home, no sedation given. And you see him beaming and all set for discharge. So when we need to achieve block success like this, it is very, very important that we need to know the dermatome, myotome, and osteotome of that particular surgical procedure. This, I think, would be the cornerstone of getting the block right. And sometimes it's important that this is just to show the dermatome, myotome, and osteotome of a particular region. And it's important to know, for example, when we do a shoulder procedure, for the same quote I would like to give, a proximal humerus fracture, you gave an interscalene block, but the dermatomal supply is from T2, that is from the intercostobrachial, which is not blocked by the brachial plexus. So it's important to give a supplementary block. So interscalene block plus the intercostobrachial block for the dermatome. In other words, The block failures can be minimized if we know what supplementary block that we need to give apart from the primary block. So this is what I quoted as intercostal brachial. And similarly, when you do the lower end of humerus surgery posterior approach, the posterior cutaneous nerve of the arm gets spared many times in spite of giving an excellent supraclavicular interscalene block. So we prophylactically do a local anesthetic infiltration in the territory of supply of the cutaneous nerve. And for that, we divide the elbow into 3 parts posteriorly. We draw a line horizontally between the upper 2/3 and the lower 1/3. So we give an horizontal infiltration there, and then a vertical infiltration reaching the elbow. It's a T-shaped infiltration that we give. The point I would like to make is it's pertinent to know the dermatome, myotome, and osteotome. And whenever you think there could be a dermatomal sparing, you need to give supplementary block. So it's crucial that we become masters in anatomy, physiology, and pharmacology. And most of the times, the factors related to failed block is purely because we have not understood what is the surgical procedure, what would be the approach. So it becomes pertinent that we discuss with the surgeon what approach you would like to go and where will be the incision and whether your block will cover all the 3 segments which I said. And over a period of time, the technical skills that we develop will produce in least block failure. And it will also, as the expertise increases, the anxiety also decreases. But most importantly, in spite of being an expert, you would not want to do any block in a very hurried manner, which would result in block failure. So once there is a block failure, or 20 minutes after giving a block, you will assess if there is if the block has not worked well. So if it's a complete block failure, then you need to look at the total volume of the drug you used. And if you think that still there is a margin of safety, then you will go and repeat the block, either in the same place or you will go for a rescue block. For example, you had given above clavicle block for a procedure of the forearm and it didn't work well. So you can go down and then do the block in the axillary region. So this is called a repeat block or a rescue block. Or you may have exceeded the first time the block you gave itself, you would have exceeded the volume. Then it's a good idea, especially if you're in private practice, not to produce any local anesthetic systemic toxicity. So my best choice would be to go for general anesthesia with protected airway, either a laryngeal mask airway or even after giving muscle relaxant, giving a complete general anesthesia. Sometimes it may not be a complete failure, but it could be a patchy block or a partial block failure. And many reasons are there. One, the drug didn't spread to all the neural tissues it should have. And number 2, sometimes because of anatomical variation. And number 3, sometimes it is prefixed and post-fixed. You think the dermatome supply is C4, but they would have got twigs from C3 and C2. This we call it as prefixed, or sometimes it's post-fixed. Though it's a C5 dermatomal level, there could have been, then the neural tissue may get C6, C7, and T1 components will come. So the nerve is called prefixed and postfixed, or anatomical variations, which is beyond us, can produce partial block failure. Here again, the pathway is similar. If you can give the drug safety margin is there, we go in for a repeat block. If not, you go for general anesthesia. Secondary block failure is when the primary block that you gave took extremely well, but subsequently, when the procedure was going on, suddenly patients started complaining of pain. This is called the secondary block failure. This could be because either the myotome and osteotome were not covered well, or it was because you used a drug which the duration of the block got over, and so the surgical surgery is still going on beyond the time limit that the block would have worked. So here again, I think it's a good idea based upon the procedure. If you have an access to the airway, best thing is to go for general anesthesia because it's very safe. And it becomes sometimes unrelated sensations. They think, the patient thinks that the block has not taken well, but the block would have taken absolutely well. But it's mainly because of a lot of anxiety. So here, the pathway is you should consult the patient and you need to assure, and we may have to start an anxiolytic. One of the good drugs we found out for conscious sedation is dexmedetomidine. The advent of dexmedetomidine infusions in the intraoperative period has been very handy, especially when you are confronted with a situation or where the patient is extremely anxious. So the last few minutes, we discussed about the methods that we need to follow to make sure that our block work, which includes arriving early, knowing the surgical procedure, knowing the appropriate incision place, knowing the myotome, osteotome, and dermatome, and choosing an appropriate block, trying to use gadgets which can make the block more precise and perfect. And in spite of that, if it does not work, either you should go for a rescue block or openly admit to the surgeon that the block is not complete, and you will adopt a very safe method of going in for a general anesthetic with taking care of the airway. The primary aim is do no harm, and patient safety becomes very, very important. So as an anesthesiologist and as a professional, the mission remains, we need to explore new indications of doing regional anesthesia in our private practice, to seek out new research in spite of being in private work, do a clinical audit of all your blocks to see what volume, how much time it took, how much successful you have been, what kind of sedation you used. So you can do a lot of research in your own field and in your place of work, even if it's private work, and to boldly go where no person has gone before, in the sense that you will explore the possibilities of defined blocks, which you can, even if you have not done, you can embark on the journey now, because the literature is available in plenty. But all the time keeping in mind, patient safety is foremost. With this, I would like to conclude my talk, wishing all of you who are attending this session all the very best. And I'm sure that regional anesthesia will become an inherent component of every single anesthetic procedure you do, because the outcomes and patient comfort seems to be the best. Thank you so much for your patient hearing.
Thank you, Dr. Bala, as always, very precise and concise to the point. We have a horde of questions. I could see the chat box. So without spending any more time, I will hand over the stage to Dr. Vibhavari and Dr. Ala. Please go ahead with all the questions. And of course, we have expert panelists. You can start off with them. Thank you.
Yeah. So we have come to the end of the session of talks, that is topics. Now we take up the questionnaire. First, we give priority to the questionnaire in the chat box. And now we have with us Dr. Venugopal Nori, senior anesthesiologist, past president of ISA AP State from Andhra Pradesh, and Dr. S.C. Parag sir, past vice president ISA National and president ISA FBF. I welcome you both, sir, onto the panel. So let's proceed with the questionnaire. So, yeah, this is for Dr. Shyam, sir. Sir, what about taking a written statement from the patient in the printed format, stated that he or she has been explained about the plan of anesthesia, its alternate risk and benefits, and etc.
Yes, madam. Printed form is pre-printed form is contraindicated, not a form which has been prepared specifically for that patient. For that patient. So yes, pre-printed form is contraindicated, where you are going to fill in the blanks. But if something has been prepared for that patient and for that surgery specifically, I think printing the document is not the problem. The problem is with the pre-printed forms where there are blanks which will be filled. So if a document has been freshly prepared, like you have written, if you print it, that is better. Yeah. So it can be.
One thing, Shyam,
Yes.
this is point to be well taken, and it should be reminded to all the practicing anesthesiologists, because most of the hospitals I know, they used to do the same thing, printed format and filling the blanks with the patient name and procedure. But you have cleared one thing new, that you have to do a separate form for every patient in a clear-cut manner.
Yes.
So you mean to say with the writing?
That's what I am saying, sir. Whether it is in writing or you have typed it and taken a print, both are equally same.
Okay.
It shows that it is specific for that patient and it has not been something which has been taken as a blanket and filled later.
Yes, it should be specific to the patient.
Yes.
That's right. Point taken. Thank you.
Sir, Dr. Parag sir, what about in procedures where patient is unable to give consent? Example, critically injured with altered mental status. And we have another question in the chat box, like patient attendants or in patient is critically ill in the ICU, patient attendants are in abroad.
Not available.
And how to proceed in such situations? Dr. Parag sir. Sir, please unmute, sir. Yes, sir.
Is it okay now?
Yes.
Now,
Yes, sir.
second question first I will answer that I don't envisage any situation where a patient is critically ill and has no attendance. Maybe the close relatives may be abroad or somewhere, but somebody has brought him to the hospital. So we interact with that person for all other things when relatives are not available. The person who has brought the patient to the hospital. And that will be legally a
So you've got muted, sir. Parag, sir? We can't hear you. You've muted.
Yeah.
Hello.
Yeah, it can happen. A head injury patient came in unconscious and a patient's attendance yet to come is the one example. And another thing is 5 years back, we got a patient from the flight when he's traveling from Hyderabad, from Delhi to Hyderabad. He was shifted in Rajahmundry because he got a fit. He was a viral meningitis and fit, and he was admitted in my ICU. So no patient attendance, patient is unconscious.
Can I answer this?
Yeah, Guru Prasad, sir, please.
Yes.
Yeah. Okay. When such a situation arises, you do ABC, airway breathing circulation, okay, and stabilize. Nobody is going to sue you for this. There are so many other decisions, like how sir told, viral meningitis patient comes or a head injury patient. You do an airway breathing circulation, intubate and ventilate and give volumes. Nobody is going to sue you for that, I am sure, because it comes in human rights. Okay. The further decisions like taking up for surgery or something, you have to have attenders for that. But ABC doesn't need any consent.
Guru Prasad, sir, if the attendants are still not there, is it okay to involve the police in taking the consent?
Yeah, we can make an information. We have to inform, but you can't wait for them to come and then you intubate the patient.
Yes,
Parag,
point
sir,
taken.
you have your finger up. Parag, sir.
I would like to add that we have a specific provisions for that in our Indian Penal Code. The sections from 89 to 92 deal with consent, and they specifically said that any act done in good faith for the benefit of the person without consent, there is nobody available for giving consent or the patient cannot give the consent, will not be taken as a offense or anything. So
all
life-saving
life-saving
consent is just not
procedures.
required.
Yes, all life-saving procedures do not
So
require a
what we are
consent, sir.
talking of head
It's very
injury
clear.
and all, see, that's
Can I
what I'm
speak?
saying. So you don't have to worry about that. You just save the patient's life. That's all. Don't worry about attendant or anybody
Exactly.
else.
Sir, can I speak, sir? Please.
Yes. Hello. How are you?
Yeah, Sukhdev Naik, sir. Good evening. Please continue.
Actually, not only emergency cases, even if a routine case, the patient is unconscious, not able to give consent, there also we can take in good faith, as Dr. Parak says. Even if non-emergency cases, but the patient is not in a state to give it consent, consent can be taken by others. So we should not tell that always the consent has to be by only in emergency cases. Non-emergency cases also, if the patient is not in a state of giving consent, unconscious, semi-conscious, delirious, so there also the other persons can give the consent. That's the point. It should, because there are so many people, so many practitioners, they must know that they should not insist on patient consent or whatever.
Fine, sir.
In
Thank
fact, patient consent is irrelevant if the patient is delirious or not neurologically intact, right? So it should not be taken.
Sir, 100% correct.
Do we need to inform the police or something?
Police only when there is a medical legal implications. Non-medical, if you don't suspect any criminal activity or any medical legal activity, no need of, because if you involve the police, the attendants will get confused and they will get afraid. Only if there is some suspicion, poisoning, something unnaturality, then only. Otherwise, in a good faith, you have to record it.
No, when
Sir, I differ
attendants
with
are
this. Sir, I differ with
available.
what you are telling. You put a word to the police station. There is nothing wrong, and you carry on with your ABCs.
Wrong, but
Okay.
it's not mandatory. If you are not suspecting any medical legal or any foul play, it's not mandatory.
Sir, it is not easy to suspect, do suspicion and all so fast. When the patient comes unconscious, you have to do the airway breathing circuit. You don't get time to suspect a poisoning or hypoglycemia or seizures. Okay, you go ahead and then.
No, that is an emergency case.
So I'm just going to ask for a timeout, please. Sorry.
Yes.
I think we understood both sides of the discussion, and I'm sure our audience are prudent enough to take what they think is appropriate. I'm just going to switch gears a little bit and ask Pankaj sir, how about consent for monitored anesthesia care in remote situations? Like you've been called for anesthetizing a small child in MRI.
Yeah, I mean, the rules have become very stringent now for all the MRI suits and anesthesia outside the operation theater. There have been rulings which have said that every MRI center or such suit should have an attached ICU. So what I suggest that all those anesthetists who are giving anesthesia in MRI or CT scan centers should have officially an ambulance standing outside the MRI center, and in case of an eventuality, patient should be able to be shifted to the ICU. In fact, all MRI centers should have a regular tie-up with the ICU, if not an in-house ICU, as the corporates do have. This has become a big problem for private practitioners actually. And I know of recently quite a few cases, patients have unfortunately died in the MRI suits because of giving anesthesia and improper monitoring. So please don't play with people's life. It's become very important that we have proper monitors and only then go ahead and give anesthesia in these cases. And consent, yes, I mean, I would not suggest anyone to go to such centers if it is not following all these proper precautions.
Thank you, sir. Very valuable suggestion. And before we leave the topic of consent, I think there's one more question on the video or audio recording of the consent. So, Parak sir, do you want to take this? So, is it better than the written consent? What are your thoughts about it? I think he couldn't hear.
Shall I? Okay, right. So, no, audio and video consents are totally acceptable legally now, because even courts, they are having this thing, hearing on online through visual. So audio, if you have a video consent, nothing like that. because nobody can deny it, and no need to match the signature or anything. Even audio consent is okay.
I have
it is
just one more
perfectly legal
small.
now.
Yeah, I have just
only
one small question. Go ahead, sir. Pankaj, sir, please.
Only one corollary to that will be, sir, a video recording can be interpreted in both ways. It can be good for us also, and it can be bad for us also. So, I mean, whether you take a video consent or not, it definitely helps in critical cases. But the your body position and what even Arun mentioned in his talk, those things have to be very careful. We have to be very careful about. It can be misinterpreted and go negative against us sometimes. So just a little bit careful we have to be about it.
Nowadays, most of the areas in hospitals are already fitted with CCTVs. So always those footings will be asked for. So it doesn't really matter.
Yeah.
Dr. Parekh sir, I just like to add one thing here.
Yes, sir.
The court of law, the legal proceedings, whenever you are taking the video consent, you have to tell the relative that we are taking a video recording of your whatever we are explaining to you. You cannot record a video consent without the permission of the attendants. That is for sure. That I law.
Agreed.
Yes, sir.
Absolutely.
Yes,
Yeah.
yes.
I was going to
Yes.
add the same thing actually.
Yes.
Thank
We
you,
are on
sir.
the same line.
Vibha, one more question in the chat box with your permission. Vibha, the timing of the timing of the consent, it should be taken on the same day. It should not be on the previous day or other. It was asked by Dr. Kapil. I think so. It's correct.
I just wanted to ask that many times PSCs are done on the previous day, maybe in an institutes. I know it's not private practice, but the consents are taken the previous day. So any thoughts on that?
Yeah,
Anyone wants to?
I'm telling you one thing. So many a times, even the anesthesia is not given by a person who has done a PSC. Because we take consent at the time of PSC, somebody else is doing the PSC. Now there are two situations. There are some hospitals where it is not guaranteed that the same person will, say like government hospitals or even our institutions, that there is no guarantee is given that a particular consultant will attend that patient. So that is already told to the patient in writing. So there is no problem. But otherwise also, because ultimate responsibility lies the person who is administering anesthesia. So even if he has not done PSC, he has to go through the previous PSC and do a quick PSC before taking the patient. That is his responsibility. He can't say that PSC was done by that person and I went by that. And at the same time, consent also we revalidate on the day. Although the consent is taken before, but on the day of surgery, we revalidate it, again take a sign, put a date and time.
Sure. Thank you, sir. Very clear. Prashanti ma'am?
Yes. Sir, Pankaj sir, can we discuss with insurance companies and government to separate our charges and give us our identity?
This I have been trying to do.
I think we are longing.
Yes, I remember during the SAP conference, I had made a mention about this. It's high time we should be doing it at the national level. I mean, the right steps have been taken by the national ISA, and hopefully very soon we will try to have a professional communication and try to get it done. It is definitely the pipeline, and hopefully in the next 1 year, I feel it should be done, hopefully. It's definitely a need of the hour.
Sir, Dr. Bajwa, sir.
Dr. Pankaj, can I speak, Dr. Viren Sharma, on this issue?
Oh, sir, yeah, great, sir.
Yeah, Dr. Prasanti, actually just to inform all that what you have asked, the problem is that on official letterhead of ISA NHQ, we have written to insurance company regulator, to different companies, to CGHS, to National Health Department, everything. The problem is hardly any of them reply to us, except for one reply where they said that insurance people, they said it is not possible for us because we have a contract with the hospital. We don't have a contract with the surgeon or the anesthetist. But yes, I agree with you. It is the wish of all of us, but it also depends on the other party. I mean, that is the central government and the insurance regulator, whether they are convinced or whether they will do it. But efforts have been done. That is all I wanted to say. Thank you.
I appreciate the efforts by ISA and what Pankaj sir and Virendra sir has just said. I have slightly a counter argument here. Me as an anesthesiologist, am I ready to register myself with say 15, 20 different insurance companies and keep following them up to collect my charges? I think that's a very interesting question to ponder upon. Each one of you must be thinking slightly differently. And we just have to see how the insurance companies bend down to our requests and how ISA takes it forward.
Vibha, at this stage, what is in my mind is that at least let them recognize us as a separate specialty. Indemnity insurance, they're taking maximum from anesthesiologists and plastic surgeons, you are aware. But when it comes down to paying us for our professional charges, they are not considering us separate. So at least when the patient is billed, the charges should go with anesthesia charges separately highlighted, and if possible, if they can be delivered directly to the patient, to the anesthesiologist, nothing like it. It's a far-fetched dream which will take a lot of time. There is a action plan which we have made, and if we can do it, let's hope for it. If we can get it done, it will be great for all of us. It's a need of the hour, basically.
Sir, is it possible like you prepare charge list for 2-tier, 3-tier and first tier,
Sir.
and give it to them?
So that is exactly why the circular, our secretary has already sent his circular about 8 months back, that please every city has to decide and work on their minimum charges. About 25 cities have already done it, but I feel we are about almost more than 200 branches. So I know that about in 50 to 60 of the cities this thing is being followed, but I feel still there are 150 city branches which this thing is not being followed. So again, I am requesting all in every city to please come up with their minimum charges. In case our discussion happens with the IRD or with the insurance companies, then the first thing the insurance company is going to do is they are going to ask every city to give their minimum charges. And if you are not ready at that time, again, all our efforts are going to go down the drain. So that's why again repeating every city office bearers, please come out with your minimum charges. If our communication goes through, you will have to surrender it or give it to the insurance companies. We are trying for it. If it can be done, it will be nothing like it. It will be the best thing for all the private practitioners in the country.
Yes, sir. Pankaj sir, I would just like to add just one point.
The charges will be based on the hospital and its a level of equipment. Like corporates have certain charges for the insurance cases. So is it is it like city based, or most of the time it is the charges are hospital based?
See, it is city based because in every city right now, if at least a city can come to a proper consensus, it makes sense. Like I know of some cities where TKR NSD is paid 2,000 rupees, and in some cities they are paid 30,000. That much is the variation in the country. That's why at National ISA we cannot come up with a separate charge structure. That is why every city has to come out with its minimum charges. The maximum can be anything. If you are in a A-grade hospital, your charges for a TKR can be 20,000 or 30,000, no problem. But if it's a private practicing single nursing home practice, the NSDs can very well take is 10,000 or 15,000, but the minimum has to be there. Maximum can be anything.
Dr. Srinivas, sir, do you want to add something?
Got to the consent where the patient attenders are not there. If we have their contact number, can we call them on video call or regular audio call and record the conversation, and can it be taken as consent? So just a query to the speaker and Dr. Parak sir, whether it will be a valid consent.
I think Dr. Shyam can answer this.
Yeah.
Any recording has to be with the consent of the patient.
Yeah.
If you do something without the consent, it is illegal and unethical.
No, consent, with consent. We can ask them.
That's
We can tell them.
the primary qualification, and Dr. Parak sir has already answered that. All the video as well as audio consults are valid. So once it has been made clear that you will be recording the discussion as a proof of that being happening, I think it would be construed as a consent. Yes, sir. Dr. Parekh was also clear with this. We had this discussion previously. Yes.
See, I will not take up any case for surgery unless there is a attendant available outside for elective surgery. So there is no question of calling on video or anything. The attendant has to be there outside so that in case of anything we have to can communicate with them. Whether
That's right, and then that attendant has to that attendant who is there outside has to give it in writing that the person is responsible for taking decisions on behalf of the patient's family or whatever, whoever is not there.
That should be part of our consent. When we are taking a consent, then only these things should be decided, not after something is going wrong or something. For elective cases, there is a lot of time. There is no excuse for not doing anything. So all these things, who will be the responsible person for him? And most of the time, it is the person who brings the patient. That's why in the consent, always as a witness, I make the attendant as sign, nobody else. Yes. Because I know that if something happens to the patient, it is the attendant who will create problem. Because patient is no more. So I already have his sign, then I am safe. So if the attendant is not waiting outside, we don't take up for elective surgery. As simple as that.
What about emergency surgery, sir? Emergency surgery.
Yeah, emergency is different. Then emergency. See, emergency, then how do you get the phone number of the, you are saying that you have the phone number of the attendant.
Sir,
can I ask you a question?
And in the life,
the Good Samaritan law will prevail.
Sir, shall I add to it?
The Good Samaritan law will prevail. The Good Samaritan law will prevail. So at least do that if possible. But otherwise, there is nothing. You cannot do anything about it. Life saving. No one is going to harm you.
That's what, Dr. Srinivas, you have to grade the surgeries.
Yes.
When we know the risk certification, whether in emergency surgery, what type of surgery you're going to undertake, is a delay of even 5 minutes or 10 minutes or half an hour is going to be crucial for the life. You have to go ahead in saving the life. No matter where they are, at least who's the owner of the hospital, who is the admin of the hospital, that person should write down that this surgery is very, very necessary for the cause of to prevent the mortality. So we are going ahead with that. And simultaneously, if it's a roadside accident, something like that, a medico-legal implications also, there is simultaneously you have to inform the police also that we are taking this surgery and we should go ahead with this consent of yours on phone. Dr. Parekh is right. How can you get the telephone number in case of emergency surgery of a person? It's difficult sometimes.
No, if we get the number. Okay, thank you.
Perfect.
Yeah, I'm just going to call a timeout on this topic and we'll move ahead. Yeah.
So I just want to ask the same question to Parag sir. Sir, many times I tell you in Mumbai at least, there are a lot of patients who come, they don't even inform their husbands, they don't inform their families. They come for breast augmentation or they come for, breast reduction, or they say they had a fall and they had to rush to a plastic surgeon and they get an elective, septorhinoplasty done, so these things without informing their family, they get it done. They don't have anybody accompanying them. And they are willing to sign, they are willing to give their address, they are willing to give their, everything. But what do you do in such cases? ASA grade 1 patients.
See, there are two aspects of it. Yes, there are two things. One is legal aspect. So they are adult people, they can definitely give consent for whatever treatment they want, there is no problem. But the practical aspect is, if something goes wrong, whom do you inform? Where do you inform? So that risk you are taking. As long as everything goes on well, there is no problem. And they are entitled to consent. Their consent is perfectly valid in law. Adult patient. But
So
for
if they
our
give,
sake,
if they
for
give a phone
practicality,
number,
No, sir,
if they
sir.
give
I
a phone
differ.
number, is it all right?
Indrani ma'am,
No.
simple thing
I-
is that you can give the consent. It may be valid for a surgery, but when you are undertaking a surgery, you are equally responsible for the
no,
post-operative
I
and perioperative
don't think it will
complications.
be right.
Sir, you have to take a consent
Yes.
of the attendant, one who has to take care of the perioperative complication. If any complication can come during
No,
surgery.
I'm totally for it, but I'm saying, is it valid? Is it
No, ma'am, no. A
medically
single
valid?
consent is not valid, not valid at all. You cannot
Right.
protect yourself in a court of law.
Yes.
You cannot protect yourself. You have to take a consent of attendant who can take care of the patient in case any eventuality develops during the operative procedure
Right.
or during the post-op period.
What about these foreign nationals who come here
Sir,
for surgeries?
because
They
consent,
have nobody with
as
them.
per the IPC, in Indian Penal Code, the consent of any adult person is legal. There is no doubt about it. But for our safety and all, we should ask for an attendant to be there. In the
That's why
law,
I
that
asked you, what
consent
about
cannot be
foreign
changed.
nationals? Foreign nationals, when they come, no, they don't have anybody with them.
Then maybe we have to inform the embassy, ma'am.
1 minute.
Correct. We have
I'll
to
tell
inform
you,
the embassy.
1 minute. In our LV Prasad Eye Institute, we are getting many foreign patients from African countries and from Middle East and all. But they are all, they have some Indian representative with whom they come. Nobody, just foreigner walks in for surgery. Because when they come to any other country, you have some contract or something. So that person comes with him. And then
Sir,
he is
Dr.
referred,
Vibhavari
he fights
Nayak
for
will
him.
know what I'm saying. For cosmetic
No, I
surgery, they
understood,
don't
ma'am.
come with people.
You're playing
No,
with
I
fire, madam,
understood.
basically.
Yeah, but for the international patients, I also wanted to say sometimes patients don't understand the language. We have also included translators' signature saying that they have translated so and so to the. So
Yes,
I think we just
we
need
have.
to involve those who are available to make sure that our message has been passed across to the person.
Translation is never an issue. We get English patients, but the
Yes,
problem is they come alone.
Yeah,
They
I
don't
got
come with other people, like how Sir said that, they come with somebody who are
Yeah.
mediating. There are no mediators. They have seen you through the internet only. And they have belief in you. They have had online consultations. They just land up.
Yeah, one query from my side
Yeah.
regarding the
Madam, you're playing with fire. It's
Indrani
not
madam.
safe. It will not
Exactly.
be safe in private practice.
Exactly.
So if something goes wrong, you are
Yes.
probably landing in a soup. So I will not do it as a private practitioner. Even I will
It
suggest
should be
no one should be doing it.
discouraged.
Yeah.
Yes, and I feel let's close
Regarding
the topic.
the
There are a lot of more questions to go.
yeah,
Please go
yeah.
ahead.
Regarding the Indrani madam's query, if the patient came alone, if the patient landed in some postoperative problems or non-ventilative support, definitely we will have to face many questions from the attendants.
Dr. Balavikara joined. I
Okay.
can see him online. Any questions for
Yes,
him? You can direct him now.
Dr.
yes,
Lori,
Dr.
one more thing I wanted to add to your, presentation. When there is a death on table, these are the days of, social media. People take videos, people, especially the servants, at that point of time when you're resuscitating, when you are doing your best, the servants are just onlookers. So what they do, many of them, they take videos, then they quietly go outside, tell the relative when before you can tell. There are so many things which can actually turn the table for you. So I think when things are just not going okay with you, just inform all the servants and everything that what stays here stays here. I think that information should go across. That
No relative
nobody
is
should
supposed.
talk to the relative except me and the
Absolutely.
surgeon.
Perfect.
That message should go. Nobody will talk to the relative.
Or the OT staff and technicians, IMRs and all.
Yes,
Absolutely.
and even in government hospitals, residents, they just,
Yes, ma'am.
in 2 minutes, the WhatsApp video will go to the other resident.
Yes.
So you have to be very careful at this point of time, because you have to inform that no one will talk about this patient except me and the surgeon.
Yes.
Perfect.
Sir, is it important to have a distress team of doctors from ISA and IMA And shall we inform them when things go wrong? And what is
Yes.
the time?
Yes,
And
in the present
are there
guidelines for
any?
city.
Actually, we have one rescue team in Kurnool. In February, one case, one young anesthesiologist, he had a massive MI because he was monitoring his patient. After he gave spinal for hysterectomy, suddenly there was pulmonary edema and he intubated that patient and they cancelled the surgery. Surgery was not started yet and the patient was put on ventilator. And he was monitoring that patient day and night. After 2 days, I think, in the night, he was in the ICU sleeping. No other patient in the ICU except that patient, that post-op or problematic patient. And he was sleeping in the ICU in one bed in the corner and he had a massive MI in the early hours and he passed away. He was hardly 38 years or 35. So after that, ISA Kurnool has formed a rescue team consisting of 2 senior anesthesiologists and they will be going wherever there is a problem or any member of ISA Kurnool will go there. If there is, if they put a message in the group and anyone can reach there and this team will be functional for, it will repeat or it will be changing every 3 months. So every 3 months, another new team will come. This is the rescue team and I wholeheartedly appreciated ISA Kurnool for taking such good step. And even I wrote to Dr. Bajwa sir also regarding that.
Yeah, ma'am, I will just come
I
to
think
that
that
now.
requires an
I
applaud.
will come to
Yeah.
that now. Already in the process of formulating a online stress line. Email, you can't say the phone lines for the ISA. We are coming up, almost half the draft is done almost. The team is being identified and we are going to put, the common email, which a team, almost members from every state, every zone will be there, especially coming to the suicide also. Not just this perioperative complication. We are concerned about the young suicides happening. I think even in this northern part of the country, we have seen 3 suicides in the last 3 months. So that to young anesthesiologists. So it's a helpline number, helpline email will be there. Number is not possible. So that will be there, will be governed by the team of the members from ISA, which will be involving the state and city branches. That is going to part of another big draft, which is going to come up. We are going to take up in the GC meeting here in 8th of June in Chennai. So that is one agenda of our upcoming part. The second part is the consent. Now, as Dr. Parak sir was saying, he was so much right about everything. In this consent form, we are getting the proposal from IMA with other specialties. We are developing a consent form and I'm in touch with Dr. Ravindra Mangal. He is the one who is the main lead in this consent form for every specialty. You have to add certain features of that particular surgery. Any complication happening during that surgery, you can't just have one consent form, just a signature there. That maybe not be sometime admissible in the court of law. You have to individualize each consent form, leaving a space. You can handwrite also. It's not that you have to type everything. On that particular patient, enumerate the problems, 1, 2, 3, 4. These are the problem in this patient, whether you go for a video consent or audio consent, whatever. But the consent form has to be holistic in way and individualized to each surgery. Especially when you are doing elective surgery, you have got ample time. And I think within a 3 months period, we will have a uniform consent form on which we can add additional features depending upon your specialty, depending upon even for our side, our surgical mortalities or morbidities, as well as in ICU also. So that consent form is also going to come up very soon. And the second part, I think I will be not divulging the details here because still working on that modality. It will be coming up in our agenda in the GC meeting when it's get passed. So we will be having a very, a big team. And not just that, we may be involving other specialties also because sometimes your own specialty may not be completely able to help those people. I think taking the help of the other specialties might help in those type of circumstances. So because suppose a gynae patient coming or you are having a problem in the gynec, complication in the gynec and the patient dies, the mortality or morbidity occurs. But if you take the opinion of a gynecologist, it helps you, overcome that stress also. So many things are there in that agenda. So that will definitely come up, and we really appreciate the efforts of ISA Kanul, which I've already appreciated when she wrote to me. This is from my side, from ISA side, on the behalf of ISA National.
Bazwa
Sure,
sir,
sir. Thank you so
congratulations.
much.
Your incredible job, Bazwa sir.
Thank you, sir. Thank you, sir.
Sir, in
Thank
Ballari,
you, sir.
in Ballari, we have got one IMA rescue team which contains all the specialists, including anesthesiologists. Last month itself, we had 2 such calls, like one death, pediatric patient death, not related to anesthesia. But whenever there is a call through WhatsApp, usually at least whoever is free, they will go and attend there. It will be like a moral support to the person who is facing the problem. We are having that.
That's wonderful, sir. Together we stand. I think Dr. Atul has raised his hand, and he also had a comment about this. Dr. Atul, do you want to say something?
Unmute yourself, Dr. Atul.
Yeah. Good evening, sir.
Good evening. Good evening.
Thank
Dr.
you very much. This such a nice topic. Also, I want to just go for the Ahmedabad example in Gujarat. We have created one AMA group. On this is WhatsApp group. Only emergency message is there. Number of times they call, some hospital have problem. So near about hospital doctors is all allopathy doctors like MBBS doctors, orthopedic surgeons, and anybody. Those are free. They reach immediately within 15 minutes. More than 50 to 100 doctors is that hospital. So anything goes wrong, the moral support from the doctors is possible. So I think we should do all the cities WhatsApp group, the only WhatsApp group for emergency people. This is created really such a good benefit. Anything goes wrong, all doctors give support. Thank you.
Yeah, this is very much prevalent even in Nashik for a very long time.
I think Bala Venkat sir is waiting for a long time, our president-elect, sir. Dr. Bala Venkat sir.
No, it is
Good evening, Bala sir.
Good evening. Good evening.
Welcome. We know you've been traveling a
Welcome
lot
back to
and you're
India.
still in transit.
Back to
Welcome,
India.
sir. Yeah, welcome back. Please,
Yeah,
could
thank
you
you so
share
much.
your thoughts on this? And I also have a question for you in the chat box. So any thoughts on whatever the discussion is going on now?
Yeah, number one, I bring greetings from 2 countries, Venezuela and Colombia. And I'm very happy to share that I presented Indian Journal of Anesthesia to all of them. I took 8 journals with me and gave it to all the department heads. I just want them to know that we are growing fast and we are progressing in the right direction. And many of them, minute I gave, they saw the book and they said, oh, this is a high quality journal. So I wanted to start with a positive note. And I also wanted to share with you, today I had to go to the Swiss embassy directly from the airport. The World Federation has nominated me to physically attend the WHO meeting in Geneva on June 11th and 12th on the Grand Alliance of Care of Injured. So I'll be representing anesthesiologists of the entire world in that GASI meeting. And it so happened I went to the embassy and they said, once you are representing WHO, the letter is there. We won't take any visa fees from you. And they said that within 2 days, the passport will come to you. So I just wanted to share the happiness that we can kind of do it to our country and make our country proud. And I would wanted many more anesthesiologists from India to come into the global platform because they need to know us more and we are capable of helping the global community to become better. So that's my first submission. And the second submission is regarding the international patients. And I think all those who are treating international patients should have a system in place. And we need to inform the FRRO office in the respective city that you have received a foreign national and the passport has to be submitted. For example, in our hospital, there is a separate department working on it. The minute the patient comes in, it is immediately informed to the FRRO and the FRRO does a survey because there can be terrorists who are involved in nefarious activities coming in the guise of getting a surgery done. And so we are supposed to inform them and then they keep a close track on what these patients do. So I wanted to submit that. And also it is extremely important to do that in the eventuality of a mortality, if we had informed FRRO, then the legal process becomes simpler. So that is one thing I wanted to convey. And regarding, I'm very happy with what our Honorary Secretary Dr. Bajwa mentioned about the strategies and plan to help people in distress. And more importantly, I think this governing council meeting, I think we are going to take the next step of decreasing the number of distress calls by making the anesthetists more competent. So a skill and knowledge-based, simulation-based training will happen all over the country, and the curriculum has been drawn. And eventually, we'll try to work on the root cause of distress, and possibly we can avoid many morbidities and mortalities. So this all comes some of my submissions. And what was the question, Dr. Vibha?
Yes, thank you, sir. Thank you, sir, for your valuable insights. And there's a question for you which asks, are there incidences of medico-legal litigations about neurological deficits after regional block? And how would you tackle them?
Yeah, that's a good question. And more importantly, I think every regional block, first I would wanted to confess that a neurological deficit due to anesthesia is almost negligible. And even in those who are using paresthesia technique, it is very, very negligible. Most of the times, it is certain other causes of neurapraxia, like the tourniquet, the positional cause, all that have to be taken into consideration. In the literature, world literature, it's less than 0.01% of neurological complications following it. That's the number one which I want to present. But number two, can it happen? We can never say no. And what if there is a deficit? And when you actually, ideally, if you see the consent forms for regional anesthesia across the world, there is a mention about the possibility of a neurological deficit following any block, whether it's ultrasound guided or not. But in India, this is not prevalent. We don't give importance to all these factors. And it is definitely when you have not informed the patient, and if a complication happens, they can definitely go to the court and sue you medico-legally. And we cannot say anything if we have not explained it earlier to them. So that would be my call. So does it mean that always you have to tell them? The problem in India is if you tell them, the surgeon will say the patient will run away and regional anesthesia will never develop in India. So there are two sides of the coin. Medico-legally, yes, but we don't see, for example, we've been practicing regional anesthesia for several years now. One of the commonest cause is because of the adjuvants added. Sometimes it prolongs for a long time. I'm just going to speak only one word technical. Based upon where the drug was placed. So there is if the drug was placed in the subparaneural space, subepinural space, it depends on where you place the drug. And even with ultrasound, sometimes you cannot make out the coverings of the nerve. So if you have placed it deeper inside, what happens is the ability of the drug to be removed by the blood vessels, the venous system is delayed, and the duration of the block is more. So most of the time, it is within 48 hours, the whole thing will become normal, and complete neurological axonotomy never happens because of the block. So with this in place, I would wanted the anesthetist to assess what has been the deficit. Is it motor and sensory both? Or is it only motor? Is it partially recovered or not? And currently, the best way to investigate that, initially it used to be an MRI, but now with the advent of high resolution ultrasound, we are using ultrasound to find out if there is a neurological injury. So this is in a nutshell about the neurological deficit. But in a case, if you have not taken a consent, if it happens, if the patient sues, definitely we have to face the court. Thank you.
Sure. Thank you, sir. Thank you for that brilliant answer. Over to you, Prashanti, ma'am.
Yeah.
We have
Prashanti, would you give me only one chance for less than 1 minute?
yes, sir. Sure.
So with the acceptance of a Bala, shall I add a small point? With the triple monitoring like pressure monitoring, ultrasound, and a neurostimulator, we can reduce the neuro complications the least possible way. I think Bala sir will support me. Thank you.
No, I think the only issue is I completely agree with you. That is the best way to prevent a nerve injury. Like number one is ultrasound. Second is the dual technique of using a peripheral stimulator. Third one is the injection pressure monitor. And there is a new device which has come. It is called nerve guard. And if the tip of the needle goes into the nerve guard will not allow you to inject the drug. So that is absolutely new.
Fascicles, intrafascicular.
No, that's what, because the pressure increases. The tip of the needle senses the pressure. And if it goes more than 15 psi, the nerve guard will not open. Whereas the previous one, Be Smart, you have to see the color coding and then stop injection. But nerve guard, and there is another one which has device now, Safira, they don't allow you to even inject, so you can't produce an injury. And one important point is, it is not the needle prick into the nerve that produces the nerve damage. It is after pricking the nerve, injecting a large volume of drug into the nerve, increasing the intraneuronal pressure, producing ischemia, and it's an ischemic neuropathy, which is the cause and just not a needle injury. Thank you so much, Venugopal sir, for that, bringing up that point.
Thank you, sir. Thank you. It's my pleasure.
Sir, Dr. Arunendra sir, I think you have one question here. In case of mishaps, for how much time should we keep the medical records of the patient?
Hello.
Yes,
Yeah,
sir.
madam. Normally, all medico-legal records have to be kept for life. Whether it's police always allows us to keep the death certificates, the birth certificates, and all the medical record to be kept for life and not to be destroyed. So there is no way we can dispose these records anytime.
Sir, Dr. Parak sir, you want to add something to this?
So
Please
you need to
unmute,
unmute yourself.
Unmute. Madam, please unmute Parak sir.
If there is any, yes, it is unmuted only.
Yes, sir.
Yes, sir. Please go ahead, sir.
Yes. There are two things involved. This is now if it's a question of criminal liability or civil liability. So if it is a criminal liability, then as Dr. Arunanda said, we have to keep the records for a long time. And especially if something happens to the child, then till he gets adult, we have to, because he can bring a suit after he becomes adult. So, and then there is a 3-year time limit also. So till he becomes 21-year-old, he can bring the suit. So till then, we have to preserve the record. But otherwise, normally up to 3 years, because 3 years limited in the court. After 3, nobody can file a suit. It is time. So in civil liabilities, it is, if there is a criminal intent possible, then it is for a longer time that we have to preserve. And in children, till they get 3 years plus that.
Sir, Dr. Balavenkat sir.
Madam, this is a completely different perspective and a question. Suppose if we get a patient who is an alcoholic and he suffers an injury, and in the case sheet, if we write history of alcohol plus, though during the time of accident, he was not under the influence of alcohol, but if you write in the history of alcohol intake is plus, the insurance company is refusing to pay them any insurance money. And so there is a conflict of whether we should note it or we should not note it. So it's been a constant source of concern for us. I just wanted to get some insights from all of you who face such a similar situation.
Yeah, this is a very tricky situation, Dr. Bala. It happened in
But I think,
yeah.
Pankaj,
This is yes, sir.
I
Please
think
go ahead.
this hiding the facts is not going to help us. And I think we all know about that Pune incident where 2 doctors have been arrested.
Sir,
for
two
changing the
instances
sample.
I can tell you, sir.
For
Two instances I can tell
alcoholism,
you. Sir, one orthopedic surgeon whom I go to, some other analyst had come there and he mentioned that the patient is alcoholic. So now the insurance company, as Dr. Bala said, they rejected the claim that he was under the influence and that's why he had a fall. Now that patient has filed a case against the orthopedic surgeon with the anesthetist as on what basis have you labeled me as an alcoholic? So what Dr. Bala has said is a very, very pertinent question. This is one
That's true, I
case which
agree.
is going on. And secondly, sir, just yesterday I was in Bombay. One of our relatives was operated. I know he's a chronic tobacco addict. He had a flap for CA buccal mucosa. And I went through his notes and I found that it was mentioned sharp tooth was responsible. So I feel what Dr. Bala is mentioned is a very important question, and maybe we have to protect the interests of our surgeons, taking them in confidence and also the patient into confidence. Because as many patients, their insurance is being rejected. And in fact, I told you this patient has filed a case against the hospital and against the surgeon. So this is a very tricky situation to be in. So what I have started doing in my private practice, I say that the patient has declared that he is not an alcoholic. I find that little safe. We are not going to go to the patient's house and see whether he is alcoholic or not. So we just say that he is not an alcoholic. That is what I have tried to do in my practice right now. Thank you.
Sir, I think as far as the insurance company denying a claim will come only if he being an alcoholic has affected the patient and caused him some particular problem. If an alcoholic has sustained a fracture due to an RTA, then the scenario changes in respects to the insurance company. But if the same the person who is having a history of alcoholism, but he had injury which is not related to when he is drunk, I think the insurance companies have their own panel of doctors where they have to be informed that this patient has sustained an injury when he was not intoxicated.
No, I beg to differ here. Yeah.
Dr. Rajendra, I also differ here.
Then we have to write in the case sheet that patient is not under the influence of alcohol.
Madam,
No,
they
no,
don't
no,
take it.
no.
No, how can you?
No.
They don't take
that's
it.
not.
They don't take it.
They don't take it.
They won't take
That is
it.
because when they have taken medical insurance, they would have written that they do not consume alcohol. So anything that is not recorded while they have taken the medical insurance and it has been disclosed later on, they reject the insurance. We faced it a couple of times too.
Yes. So best is patient denies history of alcoholism. That's all. That is all we should do as anesthesiologists.
My question here is, who is going to establish that the patient had alcohol? Who's going to establish in a hospital of a multi-specialty, you are going to have a special cell that the patient had alcohol?
Exactly.
Are you going to establish that? Nobody can establish.
We need to have, that's very impossible, next to impossible.
So my question, my question is very simple. No, the point is the minute you make it in the history that is a known case of alcohol, though he was not under the influence of alcohol when the accident happened, the insurance agency summarily rejects the insurance. This has happened several times to us. And that's why I put this question forward.
Sir, that is the reason I'm mentioning, sir. I think we have to prove a point that his alcoholism is in no way connected to the present problem or the present accident. I think there are, most of the insurance companies do have MBBS doctors who try to reject or accept the case. So even I have got some queries in this regard. So we were able to tell that the patient had accident in a scenario where he was not intoxicated and it is not related to his alcohol behavior, because most of the population, almost everyone has a problem. It's not a problem. Most of the people do drink. So if the patient sustained the injuries due to his alcoholism, then that's a different scenario. But still, we don't have any methodology to prove unless we take the blood samples and send for toxicology.
Dr. Aruna, what I say here is it's very difficult to establish that a patient had accident because of alcoholism or patient consumed alcohol and subsequently had an accident, because whosoever is going to record a history, whichever patient is going to come, in the private sector, I'm telling you, many times such patients are taken up without mentioning that history, that if you mention that history, the insurance will not be paying the hospital also, or not paying the patient also. So these things are always covered up. And forget about everything. Take example of Pune now. Pune case about that moving down. You take a sample and you throw the sample. In a doctor's hand, you can do whatever. There is a gray area here. So it's very difficult to establish with a real forensic team there or somebody coming to that particular scene that this patient was under the influence of alcohol and the accident happened because of that. So insurance company is not going to pay. So these are very, very gray areas. I think if the discussion continues on that, we will not end up anywhere,
Exactly. Yes.
Yeah.
That it's not area of a discussion in this part.
Sir, one more observation in the previous discussion. There was a query regarding a patient coming for an elective surgery without any attender. I think a patient who is sound enough, who is mentally fit to give consent for his own surgery has the courts recently, there was an incident of a dental surgery that happened in Hyderabad where the patient had come alone without any attender, and actually that patient had died due to some problem. So there was some news saying that the courts have accepted the patient had come on his own will. He is adult, and when he gave the consent, was mentally fit and strong to give the consent for the procedure. So there was no need to take the another attender's consent for that particular procedure.
No, there are two aspects here. You are legally you are perfect.
I think we lost Parak sir, and the discussion can go on and on and on.
Yes.
Yeah.
I think
It's time.
I cannot understand how last 3 hours just flew by. Thank you so much to all the audience for your interaction, for your questions, and all the panelists for such wonderful answers. I now hand it over to Pankaj Gupta sir and Bajwa sir for their closing remarks. Anything, Prashanti ma'am? Would you want to say
I think
anything?
Vibha, we missed one thing. One doctor emailed us this one. Some hospitals do not pay immediately and keep backlogs of payments for anesthesiologists, and then they start calling another anesthesiologist. How should such incidents be curbed? This is the last question. I think this is
no solution for this. They have to deal with that individual hospital.
Dr. Bajwa,
the local anesthetists have to stop going to that particular hospital as a unity. That's the only possible way, where the doctors should not backstab each other. Everyone should pass on the message in their WhatsApp group saying this hospital is not paying the dues. Until and unless they clear the old dues, no other anesthesia doctor would be available for that particular hospital.
Is it like
this comes under ethical conduct of anesthesiologists, which I feel we should probably put in a document now. Just as chartered accountants, you are aware, you cannot change a chartered accountant. If you want to change a chartered accountant, the first CA has to give an NOC. So maybe we'll have to work on something on it, but a lot of it depends on the local anesthesia branch, how strong they are, how they can negotiate with the surgeon. Probably such problems are best managed individually or at the local ISA or at the state ISA or at the national ISA. This is the step ladder pattern that one has to go through. But I feel that is the only way you can do it. The local unity only can redeem such losses that anesthesiologists are having.
The reason why we are in this state is because of our own colleagues.
And
unity, lack of unity.
It's not lack of unity. It's because the human nature. It's not among anesthesiologists. You talk of any specialties. No specialty is free of these type of corruption. one surgeon is doing a surgery at 15,000 rupees. The other may say, I will do it at 10,000 rupees. How you qualify? How you quantify? Unless and until in a city branch, you convert all the anesthesiologists into ISA membership, you cannot have unity. Nobody will listen to anybody. A fresh anesthesiologist come, he wants to establish himself. He will not listen to the senior person. And the hospital will call that, anesthesiologist lower rate, that he will go. How can you establish unity among that? There is no way to establish unity. The only possible chance is that if that person is under the umbrella of some organization and there are certain common, what you call the protocols and rules and regulations. I think before going, we should talk to Atul Gandhi, sir. Dr. Atul Gandhi, please. Unmute yourself. Dr. Atul, unmute.
Yes. Regarding this charges of the anesthesiologist private practice, in Ahmedabad, the one incident happened. The social media is more powerful.
Dr. Atul, you should turn off your video off, then you speak. Your voice is breaking. Turn the video off, then speak.
Yes. Okay.
Yes, sir.
It's okay, you can continue if it's not getting.
You gave him a tougher job to do.
Yeah. It's difficult to get.
It's okay.
I think we should institutionalize anesthesia private practice in a proper
Now go ahead. Go ahead, Dr. Atul now.
Yeah, Dr. Atul, please.
They give social media presentation like कि मेरा charges 3 साल से बाकी है ये hospital का. You can think over it. So the multiple people like on this Facebook and WhatsApp. Then they so hospital employees call the doctor and pay full charges. So we can do the same social media presentation on the this remaining charges of hospitals. We can do this.
Sure, sir. Thank you. Thank you. I see one more hand raised up, but I apologize. It's already
Dr. Vibha,
very
let
late.
us speak.
Female
voice is
Chandani.
there. Female voice
Okay,
is there.
Dr. Chandani, please.
Dr. Chandani, unmute yourself.
Hello, sir. I just wanted to know one thing. Like we are undergoing surgeries, and if there's a patient comes back to us with a foot drop, we've done a regional anesthesia, and he comes back after approximately 3-4 years. So till what time we should preserve these files? Because these are not medical legal files. We are not preserving them for the allotted time. So is there any guidelines like till when they can do a consumer case or something?
I think 7 years you have to keep the records with you if it is non-MLC. But as sir told, for MLC, it should be lifelong.
Okay. I hope that answers your question, Dr. Chandani.
I can see Dr. Ravindra Bhaskar and Dr. Virendra Sharma here.
Yeah,
Now
I
it's
got
time to
this.
wind up.
Sorry. I hope my question is clear, sir.
Yeah, definitely.
Yeah.
Dr. Chandani, there are no established guidelines for these things. These are our opinions based upon the present scenario and the legal perspectives available in our country, our nation. So I think whatever the discussion is coming out from these panel, I think that should be taken in a positive manner. We should go according to that, because we are presenting a united front here from the ISA side. So there are no specific guidelines, but I think keep preserving the file for, just Dr. Gurprasad sir said, for 7 years, and Dr. Arun said for a lifelong. I think it's always better to have all the files preserved in your department. There should be a separate department in a hospital, which you should be dedicated to the preservation of records, not just for the foot drop or anything. Any complication coming to you later on, the documentation is the only thing which can be presented in the court to substantiate your claims, whatever you want to tell in the court. So
Her other question was, I mean, up to how many years they can go to the court?
That's why you keep on doing the person cannot come after 10 years, say my operation was done and now I developed a complication. The last 10 years, I don't. Ma'am, this is very difficult to answer.
5 years, I think.
Ma'am, actually, it is around 2 to 3 years, but Courts are
See,
allowing.
what has been done is people put up a notice in the local newspapers that I am destroying the record of my hospital. If anyone has any claim, please come and claim it. So this helps them in the court of law in case there is a problem or inquiry later on.
So
This has been done many
The
times.
question was up to how many years they can go to the court?
Ma'am, they will go to court even after 30 years. They will go to court
No,
after
they
1
no,
year
sir. I
also.
think
But
only
whatever
up to
the
5
record,
years, I
ma'am,
think
there are
they
no
are allowed to
guidelines.
go.
There are no guidelines about this thing. I'm telling you.
No,
They
I
can
think 5 years, sir.
Sir,
5 years.
I think 2
Beyond 5
years,
years, they cannot
2
go to
years,
the
I
court.
think, sir. But courts have allowed cases beyond that time limit also.
That is one thing that I'm asking. We generally give an ad in the paper when we are destroying our files. So is that legitimate in the court of law or not? If the patient is coming after that, because then we don't have the records to prove anything. We cannot cook up the records. So is that legitimate in court that we can show that ad and it will be sufficient for us?
Yes, ma'am.
I think
it is legitimate.
Chandni, I think besides giving the ad in the newspaper, a
Yes,
letter
sir.
should always be written to the district health officer or the civil surgeon that we are destroying the records for our hospital, because our hospitals, whether the private sector or the corporate, whatsoever, they come under the jurisdiction of the civil surgeon. So I think a copy to them should always be very helpful for us in the court of law.
Okay. Thank you so much, sir. This was an added point to it. Thanks.
Yeah, Dr. Ravindra Bhaskar, you are on the online.
Vrinda
Dr.
Sharma was
Virendra
there.
Sharma, I
Where
can
gone?
see.
Dr.
Virendra
Vrinda
is here.
Sharma was, he is sitting there. अरे यार वरिंदर
Yes,
शर्मा
Viru is
हमारे
there.
सीनियर मोस्ट बंदे हैं यहाँ पे. बोलिए सर जी.
Thank you, Dr. Bajwa and Dr. Pankaj. Yes, I happened to attend most of the. Last time I gave my remarks that somehow if we can control the time. See, it's not the question that we have to answer every query. Question is, if you see the attendance from 160 to 170 to if it comes down to 64, and that is also when mainly all the speakers and panelists. See, literally, we should, because it's a monthly affair now. See, let us understand one thing, it's a monthly affair. And one more request to all, with due respect to all these senior persons. I mean, see, this webinar, all these speakers, moderators, panelists, I mean, really, they were all persons whom people should have come and joined to listen. So we should think of how we can see we are doing all these efforts for whom? Because when we say that at any place more than 60 to 70% are practitioners. Now, why those practitioners don't have the time to join us? See, we are doing all these efforts. It is not a discussion between Dr. Bajwa or Dr. Vibhavari or Dr. Bala Venkat. They are there to answer to queries of those who feel insecure, who are suffering in periphery. One more thing, Dr. Arnend, I appreciate and salute you. In all your slides, you mentioned about PPF and the logo. I mean, hats off to your spirit. That was one thing I really saw it in all his slides. So in future, we must try to attract as many practitioners and give them opportunity to ask questions rather than to us. I mean, I'm including myself. See, we can interact in any platform at any level. Let them ask questions at this platform. See, Dr. Bajwa, Dr. Bala Venkat, Dr. Pankaj, so many GC members, Madam Dr. Indrani, so many, Dr. Srinivasulu, Dr. Vibha, Arvind, Dr. Parekh, so many learned people are there. Let us give them opportunity to ask whatever simple query. Let us encourage them what they have in their mind. Maybe they are fearing not to ask in this discussion of academic pupils. I'm sorry, I've taken a little bit more time. Thank you so much.
No,
Thank
Dr.
you,
Virendra,
sir.
you're right. Dr. Virendra was right. Last time it was suggested that we should have a more of interactive session. And next, I think next month we will ensure that it should be more of interactive rather than the narrative lectures or the extempores. So better we will have interaction and more of the queries can be answered. 90% of the problem in India of private practitioners same, whichever zone you are. But it gives an opportunity for everyone to come on the national platform to express their grief, their grievances, so that everybody can express and interact with us. So I think Dr. Virendra Sharma's point is taken right. Last time also, and I think we will take care. Next time it will be wholly interactive session, nothing more than that.
Thank you.
Dr.
So
Sukhdev
before we log off, May I
You want
request
to add?
everyone to put their videos on so that we can take a picture?
Yeah.
Oh,
All
that'll be
those
nice.
who would want to keep their videos on, may please put so. And at the countdown, I'm going to click a picture. So 3, 2.
Just wait. Let's extend to 5. So there are a few people who are just waiting.
Okay, 5, 3, 2, 1. Smile. Right. Thank you. I have one more page. In fact, I have 2 more pages, please. I need, some more smiles, please. 5, 4, 3, 2, 1. Smile.
Just wait.
Oops. Okay.
No. I'm telling you why. You do one thing, Dr. Vibha. You do one thing. You
please.
just turn to the next page. Take the another page picture also.
I did that. I just did that. The second one was on the next page.
Dr. Bajwa, please keep your mouth open. The closed mouth smile is not good.
Ma'am,
Sir, I'm
better to
proposing
close the
the vote of
mouth in the presence of so many senior people. Better to close the mouth.
No. It's better your smile will be better with the open mouth.
we should offer a Rasagolla.
Yeah. Anything else?
With that, I thank each one of you for being here for more than 3
Same
hours.
here. I
Thank you
thank
so much.
everybody for this very informative lectures, panel discussion, and very good informations we got through. Thank you so much, Dr. Bajwa, for keeping this topic open for discussion.
And
thank you, Bajwa. Thank you, Gupta. Thank you, Vibha.
For information, everyone, this recording will be available on YouTube also from now on, after we close the session.
Okay, good night.
Thank you.
I request Dr.
Okay,
Vibha and Dr.
bye-bye.
Prasanthi to say good night and to end by saying long live ISA.
Long